Welcome, everybody, to the 8th Annual Col Institute Retina Summit. We apologize that we're not in person. Usually we do the Retina Summit at Arvo, wherever the Arvo meeting is being held, but obviously this year is virtual, so we have gone virtual. But we hope to welcome you in future years at the Retina Summit, wherever Arvo is. We're really excited that because we are virtual, we're up around about 800 registrants. So it's a very large group. And we have a wonderful faculty that is joining us, both from the Col Institute, but more importantly, from outside our institution. And we will introduce each one of the faculty members as they come up for their presentations. This is a CME event, and thank you for filling out the forms, the pre-test. We'll do a post-test so you can receive your CME credit. Understand that certain parts of this will not be CME, and those parts will be specifically described as to when we're in the CME portion and when we are no longer within the CME portion. Of course, those would be, for instance, sponsor presentations, etc. The CME provider is AKH Inc., and we're supported here in terms of our partnership as well by commercial supporters as listed at the bottom of the slide. We can never do a meeting of this size and scope without having many sponsors, so we specifically want to thank all our sponsors who are listed on this slide. We will be hearing from several of these sponsors in the non-slides. So without any further ado, I'd like to introduce our first speaker, who really needs no introduction. He is Dr. Dan Martin. He's the chairman of the Col Institute, a professor of ophthalmology at the Cleveland Clinic Lerner College of Medicine, and a close personal friend. Dan has just started to do some research in macular degeneration, so we asked him to do a discussion on the long-term outcomes of neovascular macular degeneration. What do we know, and what do we know? Thanks, Dan.
Thank you, Peter. So I have no financial interest to disclose. So I'm going to start out with the obvious. What do we know? We've been working with anti-VEGF drugs now for 15 years, and we know from a litany of clinical trials, they work really, really well. And from each of these studies I have listed for each of the drugs, there have been many, many, many papers that have flown from that. From CAT alone, we've published 65 papers. We know a lot about how to use these drugs initially. We've all adopted, many of us adopted treat and extend as sort of our preferred mechanism, but there are different algorithms out there. We know a lot about how atrophy evolves, how the corneal vascularization responds, but it's remarkable 15 years later, in fact, what we don't know. How should neovascular AMD be treated long-term beyond 2 years? All randomized clinical trials end at 2 years. AMD disease activity continues well beyond that, and the disease you start with is often very different at 2 years. In every long-term follow-up study, so we have no randomized clinical trial data past 2 years. In every long-term follow-up study, there's a decline in the mean visual acuity between 3 and 5 years. We don't really understand the why of that. We know that some eyes develop progressive macular atrophy, and it's a major problem with time, but we don't know why that happens. And we don't know if dosing frequency somehow contributes to the decline in vision that happens in these eyes. Is it just part of the natural history, or is it exacerbated by the presence of CMV? Are we under-treating or are we over-treating? So that's what we're going to do over the next 10 minutes or so, to really unpack this slide. And we'll start, of course, with CAT. These were the 5-year results. So you see the visual acuity gains between in the first 2 years are exactly what you see in every single clinical trial that's performed. Marina, Anchor, View 1, View 2, Hawk Harrier, that people do really well for 2 years. And then the trial ends, and then you go back and look how they're doing 3 to 3 years later at 5 years, vision's declined. In CAT, a lot of people looked at this and said, oh, well, the reason that happened is because you gave fewer injections after year 2, and indeed we did. In years 1 and 2 in the PRN groups, we gave 9 and 7 injections. And years 3, 4, and 5, we gave 5, 5, and 4. Same thing in the Horizon study. The Horizon study was the long-term follow-up of ranibizumab following Marina and Anchor. Remember, in Marina and Anchor, they received monthly injections of ranibizumab for 2 years. And then when the study ended, there was a mean of 4 injections per year instead of 12. And you can see how the visual acuity declined. So it's easy to look at that and say, aha, it's the number of injections that is contributing to that. And maybe that's true. Certainly, when you look at real-world outcomes, there's a nice stratification, in a general correlation between the number of injections given in various countries in general and the visual acuity results. So that certainly looks convincing. But when you look back at CAD and you ask, well, why did we give fewer injections? Well, it turns out that the main reasons were there was no fluid or CNV activity detected by the ophthalmologist, or if there was fluid, it's just a little bit and it wasn't judged to be important. And that accounted for 90% of the injections that the ophthalmologist, it was specifically chose not to on the basis of the fact there looked to be no disease activity. And then there's a number of other things that happened. There was some futility. People developed central GA. And there are some people for whom, even if you wanted to inject them, that you couldn't have. There was prolonged periods of illness. There was confinement to assisted living facility. There was the inability to participate in the exam, or the patient said, look, I'm done. So the bottom line is that it's easy to look at data in the long-term follow-up studies and say, oh, they gave fewer injections and that's the reason for it. But if you look more carefully and look for the modifiable, how could you have done injections even if you wanted to? In fact, in most cases, you couldn't have, or if you could have, there wasn't any disease activity. So when you, again, take a look at CADs, you say, well, the visual acuity was declining. What was happening in the center of the fovea? So here is the CAT cohort at baseline, and you see most people had CNV in the center. When you look at year 1, you begin to see 2 categories evolve. One is geographic atrophy, and the other is fibrosis, either non-fibrotic or fibrotic scars. And at 1 year, it was about a third of eyes that had developed GA or fibrotic scar. At 2 years, it's about half. And at 5 years, it was 2/3. And what happens, obviously, in the geometric center of the fovea, fibrosis and geographic atrophy, is it's highly correlated with development of visual acuity, or with the decline in visual acuity. So the real question becomes, would more or fewer injections increased or decreased this risk of GA and fibrosis? And while we think we know the answer to that, in fact, I would argue that we don't. Here's just another reminder that more injections doesn't necessarily always mean better vision. In the CAT, the follow-up study in years 3, 4, and 5, this is the distribution of visual acuity in people who received a mean continued injections. They had a mean of 15 injections over a 3-year period. And here's the distribution of people who got no injections after 2 years. And what you'll notice here is that there's a larger number of people, 20% versus 40%. But the problem is that a lot of these people this group didn't get injections because they had achieved futility. They'd already lost visual acuity. If you look at the people who had good vision, 44% versus 49%, 15 injections versus no injections. So it becomes very much more problematic to argue that it's the number of injections that's responsible for the decline in vision. Let's take a closer look at the Horizon study. They had a mean of 4 injections per year. One of the real problems is that this cohort that you're looking at is not the full cohort. It's only about 40% of the original group of patients. We're going to talk about that a lot in a minute. The key concept is to realize is that when you look at these long-term follow-up studies, is that the eyes that didn't enroll are generally the ones who had the worst visual acuity and anatomy. In other words, more of the bad ones drop out. And that's a very consistent feature across all of the long-term follow-up studies. And in fact, even Horizon, 4.2 injections per year in the people who maintained vision, even in Horizon, the people had more injections than the ones who seem to have lost vision. Now, it's not because they got more injections that they lost vision. Maybe there was more disease activity that led to more injections, or because the disease activity, they're the ones who then went on to lose vision. So it's a very difficult subject to unpack and to really fully understand in the absence of a randomized controlled clinical trial that extends beyond 4 years. Here's the long-term follow-up study of View 1, View 2, beautifully written paper, beautifully done study. And the View 1, View 2 started with 1,200 patients, but the extension had 323 patients. And in fact, only 18% of the original cohort was still there at 4 years. So I'm looking at a very selected group of patients. The key concept to realize is that in all of the uncontrolled follow-up studies, and that would be Horizon, View 1, View 2, CAT, and you see it in diabetic macular edema. What we just published in the network of the protocol TX, the 5-year follow-up of protocol T. It happens in every study. Pretty much who comes back are the people who are healthy enough to come in every 1 to 2 months or have good enough vision that they want to come in. In general, every long-term extension study of AMD treatment, and for DME, by the way, the mean visual acuity of those patients who drop out or choose not to participate is worse than those who participate. So why is that important? Mark Gillies reported a beautiful study that shows just how important this is. So in this slide, what you're seeing is in 1,212 patients in Australia who were followed over a long period of time, what you'll see is that you can see how the visual acuity rises, and then it kind of stays flat. Well, okay, staying flat for a long time and staying up. Turns out that at each time point, if you look at who's still in the study, the baseline visual acuity is getting better. In other words, the bad ones are dropping out. And so this curve is artificially elevated. It's propped up by the fact that the bad ones are no longer in the study. And you can see that right here when they looked even more carefully at every point of time, the eyes that stopped treatment, say between 6 and 12 months, the reason why the ones who stopped treatment, they lost vision, and then they said, I'm done. Same is true at 13 and 24 months, same is true 25 and 36 months, same is true after 36 months. In every case, in general, in every group, when the visual acuity declines, they tend not to stay in. So when you're looking at long-term visual acuity outcomes, it's really hard to know, what group you're looking at. Okay, so that's the whole discussion I wanted to have around variable dosing. So you could argue, well, okay, should I just forget this whole variable dosing and just treat everybody? Just do fixed dosing. Does that result in better outcomes? Does it result in more? And the bottom line is, I'll tell you right now, we don't know. Does more frequent dosing result in more macular atrophy? There's a suggestion it might. I'm not convinced it does, but that question's still out there. And are you going to result in over-treating a lot of patients? And that's an unequivocal yes. This conversation is somewhat theoretical because basically nobody does this. Here's one of the PAT surveys that basically shows that only about 1% of people do monthly or some sort of fixed regimen in the US. If you do that, and you've all probably seen this slide before, it's very perplexing in CAD. We saw more macular atrophy in the monthly treated patients versus the PRN treated patients, and even the group who had monthly for a year and then were switched. They were sort of in the middle, almost like it looked like a dose response effect. And then the same thing was seen in IVAN, a statistically significant increase in atrophy in the people who were treated monthly, and the same thing was seen in Harbor. Now, these are associations. They are not that they were prospective analyses that were predefined, but it wasn't a randomized clinical trial specifically to look at this question. But when you have the same association that appears in the same direction in 3 clinical trials, it is concerning. To the question, will you over-treat people? Unequivocally, yes. In CAT, there were 14% of people who had only needed 3 injections in the first year. And most of those patients never needed another injection, and many of those patients did just fine. So fixed dosing may increase the risk of macular atrophy. I wouldn't withhold treatment if I was worried about that, but it's just a concern. You will overtreat patients over time. Some patients may do well with very few injections. You will have the increased risk of endophthalmitis. There is the increased cost, and it's infrequently used in clinical practice. So what about continuous dosing? We have the port delivery system upon us. We have gene therapy that is coming along. And there are good studies that have shown that these things could be highly effective at delivering drug to the eye. Here's the latter study. We've all seen this. The median time to refill is 15 months. Here's the Archway study, which did meet its primary endpoint. Basically, it's equivalent to monthly ranibizumab at 40 weeks, and then we've since seen data at 78 weeks, and it looks very good. There's some safety concerns, but overall, the device appeared to function well. The Portal study, which is the long-term follow-up, will provide long-term understanding of surgical complications. But there's still going to be a lot that we don't know. The outcomes after 2 years relative to intravitreal injections are unknown because there's not a comparator after 2 years. So most of the atrophy that occurred in CAT occurred after 2 years. So you'd like to have some sort of comparator beyond 2 years. Further, the outcomes of PDS relative to the most common treatment algorithm, that's treat and extend, will be unknown. We've never compared the two. And to understand the relative value of the device, you need to understand how many injections are being displaced. And finally, we're not going to know if this device is approved, how eyes are going to do long-term when PDS is refilled on a PRN basis. And I predict that's what most retina people are going to do. You look at the median time to refill of 15 months and latter, and it's pretty convincing as to why you might do that. So this is my final slide. And this is not a study that's happening yet, but as many of you know, or may not know, I'm one of the network chairs for the DRCR Retina Network, which was expanded to study all retinal diseases, not just diabetes. And we've put a lot of time and effort into trying to figure out what we're going to do in AMD. And to me, the big question that is out there is, how do we treat people long-term? So this is a proposed study, and I put this out there not as the one we're actually going to do, but one of the kind of where we are right now. What we'd like to do is take a large group of patients, do a 3-arm study of treat and extend versus variable. So it's basically fixed dosing versus variable dosing versus continuous. Treat and extend is a form of fixed dosing. You just modify the interval, but when patients come in, they're getting an injection every time. So treat and extend versus variable dosing, PRN with home OCT monitoring versus continuing anti-VEGF delivery. It's a trial that we continue to work on. We'd like to follow people out for 4 years. I think we can keep people in their randomly assigned groups. I think it could provide a lot of long-term data for us. So with that, thank you very much.
Thanks, Dan. That was great. We're going to hold questions till the moderating session and the panel discussion after all these macular degeneration talks. But please feel free to put your questions into the chat box now, and we'll be sure to get to them. So our next speaker is Dr. Jacqueline Kovac. She is an associate professor of clinical ophthalmology at the University of Miami, and she works at the Bascom Palmer Eye Institute, mainly in Naples. So Jacqueline, please tell us about the role of fluid in macular degeneration.
Thank you so much, Peter. It's such a pleasure to be with you all this morning virtually at this excellent conference and discuss the role of fluid in neovascular and non-neovascular AMD. And this is such an intriguing topic because we know that fluid is not always a sign of neovascular activity, and that in select cases, residual subretinal fluid associated with macular neovascularization can be the result of both transudative and exudative pathways. And in the setting of persistent subretinal fluid on OCT management can require a more nuanced approach. So I've structured this talk so that we tackle non-exudative and exudative non-neovascular AMD, and then move to non-exudative and exudative neovascular AMD. But first, I want to briefly discuss 2 concepts. One is fluid transport. A key function of the RPE is to prevent fluid accumulation in the subretinal space by actively pumping it out. And flow across the RPE is driven by an osmotic gradient that's maintained by a variety of membrane ion channels. Also, there's the concept of transudative versus exudative fluid. And transudative fluid is thought to be secondary to RPE pump failure or Mueller cell loss. It exists in the absence of macular neovascularization, and important OCT biomarkers would be atrophy and outer retinal tubulations. In contrast, exudative fluid is associated with macular neovascularization, and OCT biomarkers would be shrim, exudate, and hemorrhage. And it's important to know that exudative and transudative fluid can exist in combination. So our simplest scenario is non-neovascular AMD without fluid. A patient with drusen and atrophy, this we know how to manage, but things become more complicated in non-neovascular AMD when fluid is present. An example of this is retinal pseudocysts and geographic atrophy. I'm sure many of us see this every day, optically empty spaces, frequently located in the internuclear layer. This is associated with degenerative changes, loss of Mueller cells, and we monitor these patients. We also see subretinal fluid in non-neovascular AMD, like a crest of fluid over the apex of a drusenoid PED is shown here, a pocket of fluid at the angle of a large druse, or a drape of low-lying fluid over confluent large drusen. The mechanism here is thought to be impaired oxygen diffusion due to increased distance between the choriocapillaris Brook membrane complex that can lead to RPE dysfunction. The RPE can lose pumping function, and then that leads to the accumulation of transudative fluid in the subretinal space. Similarly, in the setting of RPE dysfunction, you can have vitelliform material that accumulates under the retina, and we see that commonly in acquired vitelliform lesions. For completeness sake, I wanted to mention two more rare entities that can kind of muddy the waters of classification, if you will. Pvac, parafoveal exudative vascular anomalous complex, is an isolated parafoveal aneurysm that occurs in otherwise healthy patients, patients that have no vascular retinopathy but can have AMD. This is located at the level of the deep retinal capillary plexus. It could be the result of focal and progressive endothelial cell injury. It's not responsive to anti-VEGF therapy, so we monitor these patients. Exudative non-neovascular AMD is a rare entity first described last year by Bailey Freund's group in 3 patients that had macular edema without associated GA or macular neovascularization. And these patients had thin choroids and thick basal laminar deposits. This condition is responsive to anti-VEGF therapy, perhaps because of chronic retinal ischemia that can lead to elevated intraretinal VEGF levels. This is a very rare condition, still being understood. It's in a diagnosis of exclusion. So the opposite scenario is non-exudative neovascular AMD, and Phil Rosenfeld's group and others have published these beautiful images of swept source OCT and geography of robust macular neovascularization without associated intraretinal or subretinal fluid, and we monitor these patients closely. So that brings us to exudative neovascular AMD, and we look for intraretinal fluid, subretinal fluid, sub-RPE fluid in these patients. Type 1 macular neovascularization is most commonly associated with subretinal fluid. Type 2 intraretinal fluid, and intraretinal fluid is the predominant form of exudation for type 3 macular neovascularization, in which neovessels originate from the deep retinal circulation, likely because of elevated intraretinal VEGF. The lesion grows downward, penetrates through defects in the RPE, and then leads to a pigment epithelial detachment, as shown here. So how do we manage fluid in these different scenarios? Well, in patients with non-exudative, non-neovascular AMD, we monitor them. In the rare case of exudative non-neovascular AMD, we can consider anti-VEGF therapy. In patients with non-exudative neovascular AMD, we watch them closely, and that brings us to the management of exudative AMD with anti-VEGF therapy, but we know that all fluid is not equal. And we learn from CAT and VIEW2 that the presence of intraretinal fluid can be associated with worse outcomes relative to subretinal fluid. And there have been several studies since then to echo these conclusions, including a post hoc analysis of the INEYE study that looked at short-term change in fluid status from baseline to the end of the loading phase. And they found at the end of the loading phase in 270 eyes, subretinal fluid was associated with better vision, intraretinal fluid was associated with worse vision, and development of fibrosis at the end of the study. Hosseini's group looked at 20 eyes with subfoveal type 1 macular neovascularization, treated every 4 weeks with anti-VEGF therapy, and monitored for 32 months, so a longer-term analysis. And they found, similarly, residual intraretinal fluid has a negative effect on visual acuity in contrast to subretinal fluid. So in these patients with non-resolving subretinal fluid treated every 4 weeks with anti-VEGF therapy, they maintained good vision long-term. But how often do we really need to treat these patients? So the fluid study randomized 279 eyes to one of two treatment arms. The intensive treatment arm treated patients with ranibizumab every 4 weeks until complete resolution of intraretinal and subretinal fluid. The relaxed treatment arm treated patients every 4 weeks only until the resolution of intraretinal fluid before extending treatment out for 24 months. In the relaxed arm, about 200 microns of subretinal fluid was tolerated. They found at the end of 24 months, patients treated with the relaxed treatment regimen achieved comparable vision and fewer injections relative to the intensive arm. So we know, looking at the bulk of evidence that we have in our clinical experience, that intraretinal fluid needs to be treated aggressively. But in cases with select, minimal, isolated subretinal fluid, where there's no associated shrim, exudates, or hemorrhage that doesn't resolve despite frequent treatment, further attempts to resolve fluid completely may not be warranted because they may not yield better visual acuity. And there's also the notion that subretinal fluid may provide nutritional support to the overlying retina. So we look forward to future advancements in multimodal imaging that will hopefully yield more discriminating biomarkers that indicate whether subretinal fluid on OCT is a sign of neovascular activity or degeneration. I'd like to thank the organizers of this conference, Peter, Rishi, Sunil, and Dan, for the invitation. Thank you.
Thank you so much. That was a wonderful overview, really, really spectacular. So our next speaker, and again, I want to remind everybody, put questions in the chat box. We will get to them, and especially this last talk, I'm sure there were a lot of questions on it. The next speaker is Arshad Kanani. Arshad is the Director of Clinical Research at the Sierra Eye Associates. He is one of the experts on gene therapy, especially in the setting of macular degeneration. So we asked him to give us an overview of the treatment landscape using gene therapy. Arshad.
Thank you, Peter. Thank you, Dan, Sunil, Rishi, and everybody for inviting me to be a part of this great meeting. So as Peter said, my goal today is to really give you an overview for gene therapy for age-related macular degeneration. Being a part of all these trials, what I'm going to talk to you about first is neovascular AMD, followed by dry AMD. And again, we don't have enough time, so I'm just going to go through some of the highlights from these programs. And over last 5 years or so, we have actually made significant progress in these programs. And we're hoping that over the next 5 years, we'll make even more progress. And hopefully we can have gene therapy as an option for our patients with common neovascular retinal diseases and also dry AMD. Now, of course, there's a lot to learn about gene therapy because it's a different modality. It's a transformative treatment. So we still continue to learn about how the safety and efficacy of gene therapy will pan out in our patients. So looking at the two neovascular AMD programs, we have RGX-314, which is a subretinally delivered AAV8 vector, which encodes a gene for anti-VEGF Fab. They also have started the suprachoroidal in-clinic program for this therapy, and the trials are ongoing. And then we have intravitreal in-office Advmo2 injection, which is an intravitreal injection. It uses a 7M8 capsid, which has a designer capsid, which is created with directed evolution, so it can penetrate the ILM, and that takes the gene for aflibercept and results in expression of aflibercept. Let's look at RGX-314 phase 1/2A program has fully enrolled. Most of you have seen the data. It has 5 dose cohorts. These were previously treated patients who had to show a response to ranibizumab, and after showing a response, they were enrolled in the trial. patients were taken to the operating room and a vitrectomy was done, followed by subretinal injection of RGX-314 and then an air fluid exchange. The primary endpoint of this study obviously is safety and tolerability of RGX-314 in these patients, but the secondary outcomes that are super important are BCVA, OCT, as well as protein expression. As stated, these are heavily pretreated patients, and here we can see the time of diagnosis, 56 months since the diagnosis, on average 9.6 injections annualized prior to entry. So again, these are very difficult to treat patients. And of course, gene therapy is a new space, and we're gonna put patients in these trials that are high need and get some value out of these treatments. In terms of safety, I think safety is super crucial when you're looking at gene therapy. We know subretinal space is immune privileged. The good news is that RGX-314 continues to be well tolerated. One thing we have seen is retinal pigmentary changes, especially in the high dose cohort 3 to 5. 83% of patients had pigmentary changes. We are still learning about it. 68% are mild. One had a severe event with vision involvement, but there's been no reports of immune responses or inflammation outside from what we see from surgery. So that's good news that with this procedure, you're not fighting inflammation associated with gene therapy. The data here, you can see pretty impressive results over 2 years for cohort 3 with 14 letter gains. In terms of CRT, the goal here is to maintain retinal thickness and control fluid on OCT, and it appears to be doing that. And there's a significant reduction in annualized injection rate pre and post RGX-314. And of course, there's a dose response where cohort 3 and forward have shown significant improvement compared to cohort 1 and 2. Other thing is protein expression. How long is this gonna last? We have data from up to 2 years in cohort 3 with good protein levels, and 1 year data from cohort 4 and 5 showing the power of gene therapy with a single procedure leading to continuous delivery. The current program for RGX-314 includes the phase 3 Atmosphere trial, which is ongoing. Also, the phase 2 Aviate trial in Neovascular AMD and Altitude in diabetic retinopathy. These are suprachoroidal delivery. This is done in clinic. The data is expected later this year, and pretty exciting to see how we can use this gene therapy in clinic to help more of our patients. And of course, anybody in the subretinal trial will be rolled over into the long-term study. So in summary, RGX-314 continues to show robust efficacy and disease control in these patients, and is well tolerated. Again, it's gene therapy, so we need long-term data to establish long-term efficacy and safety. Now let's move to Optic Study. This is a phase 1 trial of Advmo2. As I stated, it's an intravitreal injection that's given in clinic. These were also previously treated patients. Here you have 2 different doses, the high dose 6E11, the low dose 2E11. Cohort 1 and 4 received the high dose, cohort 2 and 3 received the low dose. Cohort 1 and 2 were treated with the oral prednisone prophylaxis, which was switched to topical drops after the learnings from the first 2 cohort in cohort 3 and 4. Again, previously treated patients, heavily pretreated patients, on average about 9 injections in the first 3 cohort and about 7 injections in cohort 4 in the last 12 months before these patients were enrolled in this trial. Patient again receive aflibercept. If they showed a response, they receive Advmo2. This is a snapshot. Cohort 1 continues to do well, the high dose with no supplemental injection. There have been some supplemental injections in cohort 2, 3, and there's early data in cohort 4, but overall significant reduction in treatment burden in these heavily pretreated patients. Of course, safety is crucial. We know intravitreal gene therapy is associated with inflammation. Good news is most of the inflammation in this trial has been responsive to topical eye drops, and we have not seen posterior inflammation yet in this program, which is good news. And you know, the main thing here is that we need to control this inflammation. There's a dose response in terms of inflammation. Patients in the high dose cohort, here seen in green, had more inflammation, and then they also required more drops over time. In terms of BCVA and CST in the high dose cohort 1, as well as low dose cohort 3, cohort 2 and 3, and then cohort 4, we have actually seen good control of disease. You know, the cohort 4 data is still early, so we'll present that later this year. But overall, we have seen good disease control with a single in-office injection of gene therapy. Inflammation has been an issue. It has been addressed with topical eye drops, more work needs to be done in terms of figuring out who gets the inflammation, the role of neutralizing antibody, who needs to be tapered fast versus others. So there's all these questions which we will answer over the next several years, but pretty exciting to see an in-clinic option that is very potent for our patients with neovascular AMD. Going to dry AMD, we know CFI is a natural inhibitor of the alternative pathway of complement, and what it does is it really regulates the complement pathway, and part of the amplification loop. GT005 is designed to induce secretion of CFI using an AAV2 vector. This is also delivered in the OR. The focus is an ongoing study looking at 7 different cohorts. The first few cohorts are using transvitreal gene therapy. The later cohorts are using suprachoroidal to subretinal gene therapy using the Orbit device. We saw this data at angiogenesis presented by Nadia. 3 doses of GT005 has been well tolerated in the initial cohorts. The good news is that there's no signs of inflammation in this trial, again, partly because of the immune privileged status of the subretinal space. We have seen good transgene expression, which is dose dependent, and we have seen consistent and durable increases in vitreous CFI levels and significant decrease in BA and C3 breakdown, which is the downstream biomarkers for complement activity. The ongoing Explore and Horizon studies will look at long-term efficacy and safety of GT005 in patients with dry age-related macular degeneration. So looking forward to more data, a really exciting field of gene therapy moving forward. We hope we have an option for our patients in the future. I want to thank you for your attention, and back to Dr. Kaiser.
Thanks, Arshad. That was a great overview of where we stand in gene therapy for AMD, both wet and dry. It's an exciting field, and we'll talk more about it in the panel. So next speaker is Caroline Bommel. She is a professor of ophthalmology at the Tufts University School of Medicine and works at the New England Eye Center. And she's going to speak to us today about a new pathway. We've used anti-VEGF quite frequently and successfully in our retinal vascular diseases, but now we have this new pathway, the Tie2 pathway, that we're trying to activate using inhibition of angiopoietin 2. So she's going to educate us about this new pathway for macular degeneration.
Thank you, everyone. It's a pleasure to be here. I'll be talking about the Ang2 Tie2 inhibition with Arisumab in neovascular AMD, focusing on the Tenaya and Lucerne studies. These are my disclosures. So Arisumab is a first-in-type molecule specifically engineered for the eye. It is a bispecific antibody designed for intraocular use, one molecule with 2 targets. One Fab end is designed to be anti-Ang2, and the other Fab end is an anti-VEGF end. And these bind and specifically neutralize Ang2 and VEGF-A. There's a modified FC portion for reduced systemic exposure. Why the angiopoint pathway? Well, under physiologic conditions, the angiopoint pathway maintains vascular stability and homeostasis. And we can see Ang1 is the good player. It binds to the Tie2 receptor, causes internal phosphorylation, and this leads to tightening of endothelial cell junctions, healthy pericytes wrapping around vessels, and vascular stability. However, under pathologic conditions such as oxidative stress, the Ang2 molecule comes into play. This is released in bad conditions, Ang2 as well as VEGF. And these molecules interact. Ang2 pushes Ang1 off the Tie2 receptor, and it leads to endothelial cell leakage, disruption, inflammation, leukocyte migration, parasite dropout, and vascular sprouting. Ang2 also potentiates the bad effects of VEGF and allows VEGF to bind to the VEGF receptor and leads to leakage, inflammation, and fibronectin deposition. So preclinical studies have supported this Ang2 VEGF-A interaction. And we see in this one study in mice that VEGF-induced vascular leakage is attenuated in Ang2 deficient mice. There's other models that show this interaction of Ang2 and VEGF-A. For example, in this mouse model of CNV, we see that at 1 week, giving a combination of anti-VEGF with an anti-Ang2 results in greater reduction of leakage than compared to either agent alone. And at 5 weeks, we see that giving an anti-Ang2 with an anti-VEGF has greater reduction than an anti-VEGF alone. Here's another model that supports the use of anti-Ang2 with an anti-VEGF, and we see that giving both agents results in greater inhibition of fibronectin deposition than anti-VEGF alone. And finally, another model of inflammation that giving dual anti-VEGF with anti-Ang2 specifically reduces inflammation better than anti-VEGF alone. So we have a lot of great preclinical information to show that sustained inhibition of Ang2 and VEGF may lead to vessel stabilization, perhaps even in a synergistic fashion, and maybe greater than VEGF inhibition alone. And this may also be related to prolonged pharmacodynamics in the eye. So the potential of this dual Ang2 VEGF-A inhibition may play a role because many of our diseases are multifactorial. They may not only be VEGF driven, so this may go across a potential of multiple disease spaces. We know that the long-term outcomes in the real world fall short of clinical studies, and that there is a treatment burden for our patients and an injection burden that is very hard to sustain. We also know that there's a great heterogeneity in treatment response, as seen here from the Harbor study. So what are the potential of a dual Ang2 VEGF-A inhibition, leading to vascular stability, potential better disease control, better potential for better efficacy, and reduced treatment burden for our patients? And Arisumab is this bispecific molecule designed for anti-Ang2, anti-VEGF therapy, and it's in multiple clinical development programs for diabetic macular edema and neovascular AMD. These are global studies. Tenaya and Lucerne are the phase 3 studies for neovascular AMD, and you can see multiple investigators and participants worldwide. So to briefly describe these studies, the key eligibility factor is that treatment naive CNV secondary to AMD was what was assessed. This is showing the study design. Aflibercept was the comparator given at 3 loading doses and then every 8 weeks through the study as per the label. For the Arisumab 6 milligram arms, this was given at 4 loading doses as per the phase 2 studies. And then patients had disease activity assessments at week 20 and week 24. And based on those findings, if there was evidence of active disease at week 20, which was made based on pre-specified criteria, patients were injected at every 8 weeks. If there was no activity at disease 20, but there was disease activity at week 24, then they were put into the every 12-week arm. And if there was no activity at weeks 20 and 24, then they were put into the every 16-week arm. Primary endpoint was averaged over weeks 40, 44, and 48. And year 2, patients were treated at a personalized treatment interval, and then the study will be extended beyond 2 years. So disposition for patients in Tenaya and Lucerne was the same, with similar numbers of patients discontinuing in each study arm throughout the study for similar reasons. The COVID pandemic did have limited impact on the data. Similarly, patients missed at least, about 20% of patients missed at least 1 visit around the primary endpoint, and about 7% of patients missed at least 1 dose around the primary endpoint. Baseline demographics were well balanced across the studies. Of note is that patients had pretty good vision when they entered the study, ranging from 20/40 to 20/80 with a mean of 20/60. We can see that Arisumab met its primary endpoint with non-inferiority when it was dosed up to every 16 weeks compared to Aflibercept. Of note is that there were about 45% of patients in the Q16-week arm at the primary endpoint, and over 80% of patients were on every 12-week or every 16-week at the primary endpoint. We see the vision gains were sustained and similar between all arms and robust. and a comparable portion of patients gained or maintained vision with faricimab dosed up to every 16 weeks compared to aflibercept every 8 weeks. Similar meaningful reductions in central subfield thickness. Just quickly looking at the adverse rates, these were low and comparable between all the study arms, but of note, intraocular inflammation was low, reported in 2% of faricimab treatment-treated eyes compared to 1.2% of aflibercept-treated eyes respectively, and there were no cases of retinal vasculitis in either study. So in summary, Tenaya and Lucerne dosing of faricimab 6 milligrams, it met its primary endpoint, demonstrating that patients could be dosed at every 12 weeks or every 16 weeks in over 80% of patients in the first year. Vision results were non-inferiority. It demonstrated durability. It demonstrated meaningful improvement in vision and reduction in CST. It appeared to be well tolerated, and long-term data is pending. Thank you for allowing me to present this information.
Thanks, Caroline. That was great. I mean, we're certainly excited about faricimab and what it offers. And we'll talk a little more in the panel about sort of how we can fit this in, hopefully when or if it's FDA approved. So our next speaker is one of my other course directors. Sunil Srivastava is a professor of ophthalmology at the Cleveland Clinic Lerner College of Medicine and a staff surgeon at the Cole Eye Institute, specializing in uveitis. And Sunil is going to talk to us about this interesting finding that actually Caroline was one of the first to describe almost a year ago of immune-mediated, basically, effects of some of our newer anti-VEGF agents. Take it away, Sunil.
Thanks, Peter. It's good to talk to everybody. Thank you for the invitation and thank you for coming to our meeting. I do want to highlight 2 points of my disclosures. Number one, I served on the safety review committee for Novartis and have been a consultant for them and have done consulting for Regeneron as well as received research grants from them. So I always start my talks with a case presentation. This one's not a mystery. This is an 85-year-old female who has neovascular AMD, basically one better seeing eye versus the other, and in her left eye receiving anti-VEGF therapy. Has been pretty well stable on bevacizumab, but every 7 or 8 weeks heads down south for the winter and receives a brolucizumab injection ×2 in the eye. After the second brolucizumab injection, the vision drops to 2400. So this patient comes back up north after 1 week after the injection, has received, started on a medrol dose pack, and you can see here a fair amount of vitreous inflammation that is pretty visible. When you look at the fluorescein angiogram, you can see some peripheral non-perfusion, especially out temporally. And you can see as the fluorescein continues, there's some leakage of the nerve as well. So this is a case of a brolucizumab-associated inflammation with retinal vasculitis and peripheral non-perfusion. And we'll get to a little bit more about how this case did and how you manage it. But I kind of want to take everybody back. Obviously, we all know 2020 was a crazy year on many levels. I think for many of us in the retina community, brolucizumab was approved in late 2019, and there were some rumors or at least some hints of some cases of inflammation in late 2019. Social media has changed our life in many ways, and in early 2020, there was a social media post, specifically the one in Women in Retina, and about a concerning case of a pretty severe inflammation that occurred in a patient who received brolucizumab. And I think in the retina community, if you were on a bunch of these different chats or boards, started hearing a little bit about more and more cases. And then the ASRS update came in February 2020. The ASRS update talked about 14 cases of vasculitis that occurred, and just warning the retina community that this was occurring. By the time February came around, I think a lot of us in the community started talking about it more and more, and there was some data that from Novartis itself that there were about 4 cases per 10,000 injections, at least per the numbers in August 2020. I apologize. My control of this is just a little wacky. So as Peter mentioned, Caroline's group actually was the first to describe 15 cases that occurred in 12 patients. And what was seen in these patients specifically was a very prominent drop in vision in most, if not all, of these patients, occurring after a couple of injections. associated with a retinal vasculitis and arterial occlusion in many of these cases. This picture and fluorescein from the paper highlights it very well. Areas of vasculitis, some hemorrhagic vasculitis that occur in some of these patients, and peripheral non-perfusion and profound ischemia that could occur in many of these patients. At this point, the Novartis convened a safety review committee where we were tasked for looking at the patients who were in Hawk and Harriet who actually had inflammation, but to actually go back and look at these inflammatory cases. We looked at the post-approval cases as well and removed the imaging. And that was, I think, the specific part here was to look at every piece of information of these patients who had inflammation. Around the same time, the REST committee paper came out, and the REST committee paper again highlighted some of the findings that I think Caroline's paper showed. A lot of cases of patients who had unfortunately lost vision after starting brolucizumab with a significant amount of inflammation and vasculitis with vascular occlusive disease. Again, from the paper itself is showing this profound posterior segment occlusion, and even on the image itself, you can see the artery occlusion that occurs. The OCTs are quite dramatic, where you see a drop in, a change in the inner retina hyperreflectivity, sometimes as the earliest sign, and some profound amount of vitreous inflammation. Around that August of last year, July, August last year, the safety review committee had a press release where the findings were reported and reviewed. And at that time, the 50 cases of inflammation were reviewed, and about 10% of those cases had profound vision loss, losing more than 30 letters of 30 ETDRS letters. A significant number of these cases were associated with vasculitis and vascular occlusion. When you looked at when these cases were occurring, a lot of them were occurring within the first 3 months, but there were still some cases occurring even 12 to 18 months out. Thankfully, those cases weren't associated with any vision loss, but you can see even vision loss occurring even 6 to 12 months out. The interesting thing is, if you look at the rates of moderate vision loss between the two groups, between aflibercept and brolucizumab in the studies, it was essentially equal. So even though there are these cases, there was at least hints that brolucizumab was maintaining pretty good visual acuity results. Here's just another figure just showing the time to event in the patients for those who had intraocular inflammation, vasculitis, and vascular occlusion. Again, showing you that these things were still even occurring after a year. So what's your take-home message on this? And again, I'm going to spin this. This is not an official position. This is my position. This is my at least assessment of looking at all these cases and looking at all the papers that have come out and managing some of these patients. Inflammation, I think, on some of these cases, especially after the second or third injection, unfortunately may have been there at the first injection, but wasn't really recognized. And treatment may have reoccurred at that time. The fact that inflammation RAOs can come as even 12 months after is something to, I think, all of us to give us pause and just think about how we're treating these patients, and really kind of forces us to make sure we're watching these patients carefully. Severe vision loss is possible once the inflammation starts. I think this mandates you stop therapy once you see inflammation and begin aggressive anti-inflammatory therapy. And careful clinical exam is required once this happens. What about other anti-VEGF agents? I think we have pretty good data that shows that the inflammation rate for aflibercept, ranibizumab, and bevacizumab is quite low. The immune mechanisms, when you look at these, it could be immune reaction to the drug. Some of it could be related to silicon oil residue. John Kitchens had a paper several years ago reviewing the 10 randomized clinical trials for aflibercept and really found low rates of endophthalmitis, low rates of intraocular inflammation. And the post-marketing data that's published on the website shows the for aflibercept. So how do you manage these cases of post-injection inflammation? Again, Caroline, I give much credit to, published a very nice paper talking about this in Ophthalmology Retina in 2020. And just again, I'm going to highlight some of my take on it, but I think I would recommend everyone reading this paper because I think it gives you some really good advice of what to do. So I think for my take on this is, if you are starting a new therapy on any patient, is to counsel them symptoms of inflammation. Obviously, pain, redness, light sensitivity, flares, and drop in vision. I think this mandates obviously that we're paying attention to it when these patients call in. You need to do a very careful exam. You need to use a slit lamp that works. You need to use imaging to help identify inflammation, OCT to identify cells, ultra-wide field photography to look for vessel changes. I'd get an ultra-wide field fluorescein angiography if you know it's there. I'd look at the last image if these patients have already started on therapy and look and see if there's inflammation on the last image that maybe you missed. Rule out infectious endophthalmitis, obviously, with your clinical exam. Use your gut on this. If you're not sure, tap and inject, and quickly start on oral steroids. If you're highly suspicious of inflammation, don't re-inject. Aggressively treat with steroids. If there's vasculitis and retinal artery occlusion, this mandates high-dose corticosteroids. I go up to 80 milligrams. And if you can't use oral steroids, and I doubt that, even for a short course, consider IV steroids. And I'd be careful about putting intravitreal steroids in because you need to make sure it's not an infection. So back to that original case, that patient was started on prednisone and was after several weeks, could actually see improvement in vision. The inflammation started to settle down. The opacities improved and continued to improve. And by we got 16 weeks, the patient actually was doing quite well with 20/40 vision. You know, the drug works. And I think this case, of just to end with, just highlights how well I think the situation many of us are in. This is a patient who has neovascular AMD on aflibercept and still had persistent fluid, switched to brolucizumab, had a really nice outcome with it. The ASRS report comes out, and after talking with the patient decides to go back on aflibercept. After a couple of aflibercepts, the fluid starts to come back. Long discussion with the patient, and the patient decides to get brolucizumab. Unfortunately, after getting the brolucizumab, they start to develop inflammation, even though they were previously treated without any issues. Quickly recognized by the ophthalmologist, who did a great job, started them on steroids and tapered off. Patient does pretty well, but now has recurrence of fluid again. So in conclusion, brolucizumab-associated inflammation occurred in at least 5% of patients who were in the Hawk and Harry trials. Occlusive retinal vasculitis has not been seen with other anti-VEGF agents that are approved and on the market. The etiology of this inflammation is still unknown at this time, and I think any cases you see of this warrant aggressive therapy for those who develop it, and careful evaluation is required, even those patients who do not have inflammation. Thank you very much.
Thanks, Sunil. So I invite all the panelists to come back, and we'll start with some of the questions. And we'll start with you, Sunil. One of the questions was, can you ethically use brolucizumab in the setting of these adverse events? I think you answered it a little bit at the end, but sort of what are the ethics of this? What do you discuss with your patient? How do you bring it up?
It's hard. I'm retina and uveitis, and I tell my uveitis patients are usually not as happy as my retina patients. But this kind of event turns my retina patients into uveitis patients, and it's a challenge. I think as first line, I don't use this. I haven't because of the risk, and I think the safety data with the other medications. And I'm a bevacizumab user. That's where I start. But there are cases of patients who aren't going to respond, and that last case kind of highlighted it, where you have some good clinical response with brolucizumab. I think you have to talk to your patients very carefully about them. I think you have to inform them, and you have to watch them very, very carefully. So you can ethically do this. I do think you can. Remember, the majority of patients in the study had a very positive outcome, but this is something that warrants high amount of clinical vigilance.
Dr. Martin, you've talked a lot about this long-term management. You talk about treat and extend. What's the exit strategy with treat and extend, or is there an exit strategy?
It's one of the most commonly asked questions, and I don't have the magic. I don't pretend to know the answer. There was a very nice paper published recently from a Canadian cohort, and basically looked at people once they got out to 12 weeks, if they'd had multiple 12-week intervals between treatments, that they randomly assigned those patients, if I remember correctly, between discontinuation or actually maybe they just stopped. I'm blank. The bottom line, about 50% of people at 12 weeks who were getting injections every 12 weeks were able to stop treatment over the next year. So I think it's a reasonable strategy. I think you're obviously going to keep in mind whether or not the patient's monocular or not, and obviously discussion of the patient's risk tolerance.
Dr. Kovac, we have this entity that was first described at Bascom Palmer by your group and Phil Rosenfeld, this non-exudative AMD, which is new. First of all, if you don't have this beautiful Plex Elite swept source device, how do you recommend we first diagnose it? And then how do you follow patients and at what interval?
I think the first step is definitely OCT. On OCT, you can see those pigment epithelial detachments. You can see the absence of fluid, but you can also, do a fluorescein angiogram. You can check for leakage. And then, I follow these patients relatively closely because you don't know when these lesions are going to start to leak.
And when you're following them, what are you looking for? Just exudation, or is there something special on the OCT that you're looking for besides exudation?
If you notice growth of the pigment epithelial detachment that happens suddenly, or intraretinal fluid, subretinal fluid, hemorrhage, exudates, anything like that is certainly a clue to activity.
So Arshad, yeah, you have done a lot of gene therapy studies, and one of the questions on a chat box was, there was a recent, very significant IOI in the Advmo study. Is this something that is portends future, or is it just a one-off type of issue?
Peter, the event that was reported last week was a SUSAR, so serious unexpected event in the Advmo Infinity trial. So of course I presented the data for the Optic trial, and because of that event called as panuveitis, vision loss, and hypotony, the study has been unmasked. So the sponsor unmasked the study and is collecting data, but it wasn't the high dose of 022. So as I showed you in Optic, in patients with neovascular AMD, the high dose clearly had more inflammation. And to me, it appears that it's a dose-limiting toxicity in a patient with DME. So, of course, significant concern about any patient losing vision in any trial, right? We have 60+ trials, and any patient that enrolls in a trial, our job is to protect their vision, not have them lose vision. At this point, there is, more questions than answers, and I'm looking forward to the unmasked data to see exactly what happens. As I said earlier, I think gene therapy is a new space. It's a transformative treatment. Even though it's an intravitreal injection in clinic, it is not your anti-VEGF injection. You're injecting billions of vectors. So I think this gives a pause for all of us in gene therapy space to look at this event and learn from it so it doesn't happen in the future.
So Sunil, this is interesting. We have these drugs that have amazing ability, in particular, to extend some of our treatment intervals, which is an unmet medical need. But we're seeing inflammation all of a sudden. We saw it with brolucizumab, we saw it with the abicipar, which received a CRL, so it's not approved. We're seeing it in some of the gene therapy studies. From a uveitis standpoint, how do you feel about some of the risks of some of these new drugs with the IOIs? And maybe you could sort of put on your thinking cap and come up with maybe some reasons why we're starting to see this, where with some of our older anti-VEGF agents, we saw it, but we didn't really see the vasculitis and occlusive vasculitis.
Yeah, I think, it highlights again how lucky we've been in many ways. There's sometimes we roll the dice and the dice work in your favor. And I don't roll the dice that often, but I think a couple things. One is in the world of uveitis and using systemic biologic agents, it's not surprising to see inflammatory events from the medication itself. So in the world of Remicade, Humira, these are the sort of things that we are aware of. We can measure antibody levels. It affects their efficacy and can give you inflammatory side effects. Sometimes we have to actually put patients on immune suppression to prevent those sort of things. So the fact that we're seeing it in the eye is not surprising, I think. I think it was a matter of time. It was a matter of which a biologic agent was going to lead to it. Now that we're seeing it, I think, some of this is to your point, Peter, is one, what's the mechanism? Well, I think the mechanism, is starting to become a little clear with some of these, because again, if you think of this from a systemic biologic point of view, it's got to be autoimmune antibodies or, antibodies to the therapeutic itself that we all express at some level. And is it enough to limit its efficacy? Well, it could. Could it make it dangerous to the patient because of severe inflammatory reaction? Absolutely, we've seen it. So now there's going to be this trade-off between therapies that we have used now 10 years, 15 years coming up that have an incredible safety data, but maybe are quote unquote inconvenient. But are we going to try to give up convenience to maybe get longer acting therapies that have higher risk? So some of these things on gene therapy has its own set of issues with inflammation that we're learning about, and we're going to see. And it's not just in AMD, but this is stuff that we're going to have to all address and figure out what's going to be the best thing for our patients. We're not done with these inflammatory events. They're going to continue with every therapy that we see.
So Dan, another adverse event that you talked about, which maybe it's just natural history, maybe it's just all patients eventually are going to develop this over time, is the idea of macular atrophy in a setting of wet AMD. And we could even talk about geographic atrophy in a setting of dry macular degeneration. With all these long-term treatments that we're starting to see, which obviously is great for our patients, it's great for our practices. What is your concern about some of these newer and longer acting therapies leading to atrophy?
I'll start out by saying, in CAT I think was the first study to identify the possibility that increased dosing may be associated with more atrophy. And again, as I mentioned earlier, seemed to be present also in IVAN and in Harbor. It's a concern. I don't know if it's real. That makes me very concerned about gene therapy, because you can't turn it off. You have continuous dosing of anti-VEGF, and same thing with PDS. So far, what we've seen short term in PDS is that it doesn't look like the atrophy is a big problem, but most of the atrophy that we've seen has been farther down the road, which is why I'm so interested in studying it. So it's a concern. Can I also, Peter, if you don't mind, I did a poor job on the last question you asked me. I really misquoted this paper, and I really would direct everyone to it. I said it was Canadian. It wasn't. It was terrible. It was a Swedish study. And it's the best paper I've seen out there on when can you stop, or providing information about if you get to every 12 weeks and treat and extend, what happens if you stop. They looked at 105 patients who had 3 consecutive 12-week intervals and a dry OCT at each of those intervals. And so what they did was they stopped therapy, but they followed people very closely. And about 50% of those patients remained disease-free, didn't need an additional injection for a year. 50% of them recurred. Of the people who recurred, some of them recurred asymptomatically. They were being seen regularly. They had only a mean 3-letter decrease in vision, and they got that right back when they resumed their treatment. So I would really suggest everyone take a look at that paper. It's the best paper I've seen on what do you do at the tail end of treat and extend. It was in Ophthalmology Retina in 2021.
Thanks, Dan. Caroline, you described this new drug, Arisumab, looks amazing, looks exciting. And more importantly, the IOI rate was very low. Let's fast forward maybe a year and a half. We're no longer wearing masks. We're able to meet in person. How, and Arisumab is approved. How do you see yourself treating your patients with AMD, a year and a half from now when you have Arisumab? What patients would be best for this? And sort of how do you think you're going to put it into your arrows, your quiver of arrows?
Well, anytime we incorporate a new medication, I think you can do no wrong by following the clinical studies. So they looked at treatment naive patients, but we're all driven by the patients who are difficult to treat. Those are the ones who really may benefit from a new mechanism, right? Especially someone who's had, some of my difficult patients have had even an anti-VEGF at an interval less than every 4 weeks. Sometimes I'll give them an injection. I'll see them a week later to see, okay, they're responding. It just doesn't last 4 weeks. And I think those are the patients who will benefit from this. So I would probably switch difficult to treat patients first, and maybe new patients who I think will not be able to sustain a durability of every 4 weeks. And you know, it's really a safety factor. If it appears to be safe, it will. But something that you were mentioning with Sunil before is that from back in 2004, 2005, even the drugs that we have now that are so safe, there were issues with inflammation when they were first introduced. I think we feel that the anti-VEGF and the anti-VEGF plus kind of scenario is safe, like the eye's immune privilege, but it's when we go into newer, completely new things like gene therapy, you know, we're taking it to the next level and we don't know what we'll find. But I remember I was at a meeting, Peter, in like 2002, and we were talking about injecting steroids in the eye, and people were like, oh, I would never do that. We're so immune now to intravitreal injections, you know, we're like, yeah, so nonchalant about it. But, you know, we have to go back to the way we were before and really think about why we're doing what we're doing.
No doubt about it. Arshad, you know, one of the things we didn't really discuss in this AMD section is sort of dry macular degeneration, in particular geographic atrophy. As you know, you're so involved in clinical studies. Could you give our audience just kind of an overview of GA, sort of what excites you in terms of management of GA in the future? Obviously, nothing is FDA approved.
Yes, Peter. So I think, you know, we all see these patients lose vision, as Dan said, over time from atrophy. And currently we don't have anything. We have several programs that are ongoing and we expect data from them. So APL2 is a complement C3 inhibitor, had positive phase 2 data, the Philly study. And we're expecting data later this year to see if we can slow down the growth of GA. We have Zymura in the GATHER2 study, which is a C5 inhibitor, to see if we can inhibit, you know, the complement system as C3 or C5 and to see the efficacy. As you know, the GATHER1 trial was a phase 2/3 trial, which showed positive data with slowdown of GA. Of course, you know, people talk about occurrence of CNV with treatment and complement inhibition, but obviously our goal is to slow this down. Then, so these are the inhibitors. Then you have enrichment with CFH or CFI. As I presented, the GT005 is a gene therapy, so it's kind of more like one and done treatment, which leads to secretion of CFI. And the hope is that you enrich the patients with CFI, and especially the ones with the variants. So it's looking at variants in the Explore trial and non-variants or all broader population in the Horizon trial. So we can see what happens to these patients. Of course, the focus study I presented is the safety study. And so we'll generate more data. We know it has downstream biomarker activity. We just don't know about the efficacy at this point. And you know, CFH is Gemini, Gem103 that I presented the data before, where you are enriching that with injections. And then they're also looking at variant and non-variant. So very exciting times. And you have NGM with also another C3 inhibitor in phase 2. So there's a lot going on, but I think the closest to the data will be APL2 later this year. And then once GATHER2 recruits, it's going to be available in a year or so. But Peter, I want to get back to what you and Sunil were talking about, right? We have a really high bar for safety. We have great agents for our patients with neovascular AMD, and any agent or treatment that comes in has to be comparable. So Arisumab, as Caroline showed, is comparable. Gene therapy is a transformative thing, right? It's one and done. And of course, we can't turn it off, as Dan said, but I think we have to see where the risk-benefit profile of these treatments are. But remember, subretinal gene therapy is immune privileged. So both GT005 as well as RGX-314 programs have not shown clinical inflammation. So I think I just don't want the audience to think that all gene therapy has shown inflammation. Intravitreal, we had data in non-human primates, but that inflammation went away without treatment. And in the Optic study, we have seen great, management in terms of, the lower dose, which was going to go forward with topical drops. But of course, in Infinity, with the high dose, we saw the SUSAR. So I think the field is evolving. We are learning a lot, but I don't want the audience to think that all gene therapy causes inflammation and we're going to stop it. No, we're going to continue to innovate and continue to learn and see if we can pan this out as an option for our patients.
Great point.
Yeah,
great point.
Yeah, if I can jump in, Peter, on that one. I mean, I think you're right, Arshad. I mean, I think you can't say that every gene therapy is going to lead to inflammation, right? We don't know that. Also, on the flip side of that, I think we also have to be really looking for these changes or looking for complications, or we have to change what our bar is, right? And I think we have to be over. I mean, I don't think anyone expected some of these things, and sometimes the inflammation is in places you don't expect. So yeah, I mean, I agree with you. This doesn't mean that we're done with gene therapy. We shouldn't. I think it's an exciting field. There's so many potential possibilities here. It's also going to be, as you pointed out, what if you're changing this from an injection to, well, you don't need an injection anymore, but you need to take some topical steroids? Is that an acceptable profile for patients? Would patients do that? And I think there's probably a level of that. Yeah, they would. So I don't think this turns everything off. I just think we have to be aware that there are going to be some issues that we have to look really carefully for, and we should do it now in clinical studies and overlook for inflammation.
We'll all become uveitis specialists, Sunil.
We, as retina specialists, we do it all, and inflammation is not out of our wheelhouse. It's part of what we do.
No, I think I agree with you.
Absolutely.
I think what you are saying, and I've learned that being part of all these trials, if you don't look, you don't find it. And then you have to look for other things that are not common with anti-VEGF agents. You have to look for, other signs of inflammation in the eye. So I agree with you. I think very exciting field, lots of learning to do moving forward.
Well, I want to thank my panel. This is a great first session. For those of you who just want CME, this is the end of the first section of CME. We're going to move on now to the general, a break from the general session. This is non-CME, just need to say that for our CME provider. I want to announce we did a drawing for those members, audience members who are present at this event so far. And Timothy Wang, congratulations. You have to be present to win, but you will receive a $100 Amazon gift card. We're now going to move on to sponsor presentations. Again, this is non-CME. And then after those general sessions, we'll move back. After the exhibitor sessions, we'll move back to the general session. So if you don't want to stay for this, you do not. But we will have a drawing for those of you who do stay. And the first speaker is David from Regeneron. And then the second speaker will be Shamika from Genentech Roche. So David, please go ahead.
Thank you for coming back. We're excited to begin this session of the summit. Thank our sponsors again for those two informative talks. I'm really pleased to introduce a good friend, Mark Barakat from Retina Consultants of Arizona. Mark is a former fellow from Cole Eye Institute and is currently the director of research at RCA. He's going to talk to us about when anti-VEGF fails in DME, when and what to do. Mark, take it away.
Thank you so much for having me, Sunil. It's my pleasure to be here. So as you heard, my talk is when anti-VEGF fails, or as I like to call it, when anti-VEGF breaks up with you, how to cope. And here are my disclosures. So the first question you have to ask yourself, how do you define treatment success and or failure, right? So you look at Protocol I, and approximately 40% had persistent DME at week 24. And if you follow those out from week 24 all the way to year 2 and 3, you see a significant percentage still has persistent DME. If you look at Protocol T, you see something similar at week 24, of course, broken out by different agents. And this is not different based on the baseline visual acuity. So if you follow those patients out, you see a significant percentage at year 1 and 2, approximately between 40 and 60, 70% or so, had persistent DME as well. So this is a real problem. So the question is, how does this really affect their final visual outcome? And the answer is not so much, at least at first blush, right? With continued treatment, patients gain about 8 to 15 letters. Look at week 52, week 104, whether or not they found the yes columns, they had persistent DME at week 24, and then no column. So there's no clear impact, even though there was an impact at week 24 and was clinically significant and statistically significant. This, to me, at least, is an example of the OCT visual acuity disconnect. So if we can't use this to predict, failure, if you will, what can we predict? So if you look at Protocol I again, If you look at just the anatomy, at those that responded robustly with greater than 20% CRT reduction, or those that are limited response, less than 20%, they tended to cluster together. If you look on the left-hand side, had a less than robust response at week 12, and they continued all the way out to year 3. Similarly, those that responded well at week 12 tended to respond better throughout. So we can use that to guide us in terms of helping us to predict the future somewhat in terms of anatomy. But how about vision, right? If you look at visual acuity and you use 3 cohorts, and we've all seen this, less than 5 letters, 5 to 9 letters, or 10 letters, you get these categories here. You see at the 1-year mark, we get these wonderful swim lanes that we've seen before, and you can follow them all the way out to year 3 as well. So the question is there something magical that happens at week 12 that helps us predict the future? Should we be doing something else? And if so, what should we be doing, right? What are our options? So our options are, as I see them, are these: anti-VEGF agent switches, switching to steroid, possibly laser, or other options. So talking about anti-VEGFs, pros and cons, right? So multiple limited data series have looked at this retrospective case series. Switching to ranibizumab, switching to aflibercept has shown some improvement in terms of visual acuity and anatomy as well. However, if you look at the con side, if you look at another retrospective case series, these actually patients were not switched, but they were, eligible for switching in one of the trials retrospectively, and they did quite well, actually continuing on their current agent. If you look at gaining of 3 to 5 letters. If you look at another retrospective case series looking at 56 eyes that were divided into switchers and those that were not switched. And here there are group 1 that stayed on the same therapy for 18 months, and group 2 switched not once, but twice. And if you look at their visual acuity superimposed, the switchers are in red, the non-switchers are in blue. 6 months after switching the second time versus 18 months after staying on the same therapy, the visual acuity is about the same. Not a strong argument for switching. Well, what about anatomy? At first blush, there is a difference, but if you actually look at the difference between group 2, it was actually not significant. So this is mainly driven between groups 1 and group 1B. And if you look at the primary outcome, right, those 10-letter gainers, 10-letter losers, again, there was unfortunately no great difference in terms of switching or not switching. So what about steroid, right? Maybe it's time for steroid. What's the rationale for steroid in this? We all know there's high levels of VEGF in this disease state. We also know that there's high levels of many other factors as well, inflammatory factors, that if you're looking at this case series of bilateral treatment, you treat one eye with a steroid, one eye with an anti-VEGF, you see that the anti-VEGF is good at dealing with one factor, and the steroid is great at dealing with multiple factors. These factors, of course, are involved in multiple processes which are damaging to the cell and could be impacting diabetic macular edema. So what's the argument for switching to steroid? Again, there's multiple different case series that have looked at this, and they have shown some anatomic and visual acuity benefits as well. Now, the only downside here is they are so heterogeneous in terms of their definition of refractory DME and the previous treatment. The question is, how do you draw an overarching conclusion from this? Is somewhat difficult. The most convincing data to date, I think, is Protocol U, which looked at eyes that had persistent diabetic macular edema after 3+ injections of anti-VEGF. And just to be consistent, they then continued to treat these with another round of 3. Of the 129 eyes still remaining, as you can see, the other eyes dropped out because continuing with anti-VEGF works pretty darn well. You randomize these 1-to-1 to continue on the same course or get dexamethasone. Unfortunately, the visual acuity differences were not statistically significant, but there was an anatomic benefit at month 6. So the question is, if you have something as an anatomic benefit, will it help in the long run? And so the other question you have to ask yourself, are we looking at treatment failure the right way? We're looking at it currently as a snapshot at week 12 or week 24. Should we be looking at the entire year? If you look on the right, this category in red has constant activity from visits, 12 to 14 visits of constant fluid. And if you group patients in this category, what's their visual outcome? And you see that those patients tend to do worse. It's intuitive, fluid is bad, right? And if you look, is it significant? There is a statistical significance here. So the question is, if we have an agent that can help address this, will it help shift that curve towards better vision, right? And that has potential and has yet to be determined. So Of course, you can't talk about DME without talking about laser. I will stand by. Is it still worth a try? Well, you know, we know it's a limited role. If you look at, again, protocol, with deferred laser or prompt laser, you follow that path out, you superimpose it on Ride and Rise, which is also a ranibizumab trial in that sense. And those curves are very similar. That said, I would still consider an extrafoveal components, perhaps to lessen the treatment burden in the future. What about other options, right? We've tried anti-VEGF switching, we've tried steroids, we talked about laser. What about other options? What about vitrectomy and membrane peel? The real question is it DME as a really macular pucker or macular traction? And this was first described many years ago and has actually been shown to be an effective option in these settings, and actually quite successful if that's a multifactorial component. So remember to look at this as not just a diabetic problem, but a macular problem. Are there any other angles of attack? So in short, DME is a complex process. We all know this. We also recognize that anti-VEGF is the gold standard. The treatment, the definition of treatment failure is very amorphous. And so I think one of the things that we need to look at as entire practice is whether or not we can come up with a better definition that will help us then guide us in terms of how to treat this. There's some predictive utility with what we know to date. You can base switching agents, adding steroids or other options on this, but above all, what this has shown us, that really there's nothing that can beat persistence. If you continue to treat these patients with persistence, then they tend to have a pretty darn good outcome. And with that, I thank you all for your attention, and I look forward to the discussion.
Thank you, Mark. Great talk, and please, I encourage the audience to post questions in the chat, and we're going to get to as many as we can during the panel discussion. And as you can tell, Mark has always got an entertaining thing to say and informative at the same time. It's my pleasure to introduce my partner, Kat Talcott. Kat is an assistant professor of ophthalmology at the Lerner College of Medicine. She is a practicing vitreoretinal surgeon here at the Cole Eye Institute at Cleveland Clinic. She's going to talk to us about the promising therapies for retinal vascular disease. Kat, thank you for coming.
So much for the kind introduction. Let me just make sure I can advance my slides. Here are my disclosures. So obviously there's been great innovation in terms of the management of diabetic retinopathy and diabetic macular edema. However, there's modalities with better efficacy and longer durability are still needed. So there's many ongoing trials that are aimed at validating new treatment options. This includes new drugs, advancements in the way established drugs are given or in terms of their dosing, and entirely new ways of treating this condition. So I'll provide an overview of some of the phase 2 and phase 3 studies that may change, hopefully, the management of DR and diabetic macular edema. So first is an entity that we've talked about a little bit already today. Arisumab is a humanized antibody that's bispecific and targets both VEGF and Ang2. So the anti-VEGF component helps to inhibit vascular leakage as well as neovascularization. And the anti-Ang2 component has been helpful to stabilize vasculature as well as to hopefully help reduce inflammation. There are 2 studies looking at DME, phase 3. Yosemite and Rhine enrolled almost 2,000 patients, and 2 of the treatment arms looked at giving the drug 6 milligrams every 8 weeks after a loading dose, as well as there was a personalized treatment interval that I think is very interesting and sort of helps to mimic what most of us do in practice, which is treat and extend, and took into account patients' vision as well as their CST. So in looking at these 2 studies, they found that the visual acuity gains from baseline with the experimental medication, either at Q8 weeks or up to 16 weeks in the personalized treatment interval, were found to be non-inferior. Additionally, which is also exciting, is that there were favorable anatomic outcomes seen in terms of looking at imaging. So the company looked at change in CST from baseline and found that there was improvement compared to aflibercept when looking at both the Q8 week arm as well as the personalized treatment interval that included patients who only got treatment up to every 16 weeks. Other options are looking at medicines that have been approved for other indications in DME. Based on the positive results in the Hawk and Harrier studies. This led to the approval of brolucizumab for wet AMD, and the potential benefits, as we know, that sort of are from this medication are based on the low molecular weight that allow it to be given a larger molar concentration compared to other established drugs. So safety and efficacy is being looked at in 3 different DME trials, and obviously, given some of the concerns post-approval, safety will be top of mind for these studies. So the 3 studies, so Kestrel is a non-inferiority study that looked at DME patients, and patients received either the 3 milligram or 6 milligram dose of brolucizumab, followed at an interval of every 8 weeks or every 12 weeks. And they enrolled 571 patients. The study found that it met its primary endpoint of non-inferiority at 1 year. KITE is the Peripheral international study that enrolled 360 patients, and it also met its primary endpoint. Finally, Kingfisher is a 1-year study that's still ongoing, that's looking at 6 milligrams of brolucizumab given every 4 weeks to monthly aflibercept. And so that study enrolled 521 patients. In addition to sort of already approved medicines given as an injection, there's also a lot of excitement in giving medicines that are approved in sort of different ways than just by injecting a needle into someone's eye. So port delivery system or PDS is an example of this. It's a small device that we heard about sort of earlier today already, that's slightly longer than a grain of rice, that's surgically implanted into the eye and is designed to continuously release ranibizumab into the vitreous. It's placed under the conjunctiva and fixed to the pars plana without any sutures. And it's refilled using a needle in the office. So we had the opportunity at Cole to perform several of these surgeries, which I have an example of. I'm not able to see the video, unfortunately. If one of the tech support can help me with that. Let's see if I can bring this up. So as you can sort of see in the video, obviously attention is first paid to taking off the conjunctiva and the tenons and achieving good hemostasis. And then the port is actually filled with the medicine. You can see that as the medicine goes in, you can see a small dome at the top, and that shows the semi-permeable membrane that allows for diffusion of the medicine. And then the incision is made 4 millimeters back from the limbus, and the incision is made 3.5 millimeters. Using an MVR blade, you need to dissect the sclera down to the pars plana, and in order to minimize the risk of vitreous hemorrhage after the sclera is taken down, you really need to make sure that it's the right size. So here we're measuring that the incision is indeed 3.5 millimeters and not larger to make sure that the port doesn't aggravate the sides of the sclerotomy. And then in order to decrease the risk of vitreous hemorrhage, endolaser is actually applied to the pars plana bed to really decrease the risk of hemorrhage. The sclerotomy is then completed using the blade here. And then the port is placed carefully into position, and you can see that it should seat nicely without using any sutures to be able to hold it in place and tapped into position. And obviously to decrease the chance of conjunctival erosion or endophthalmitis, careful attention to closing the conj is really important. So PDS, in terms of diabetic retinopathy, is being looked at in 2 different studies. So the Pagoda study is looking at diabetic macular edema, and these patients were randomized either to get the implant with set refills or to get injections. And the company is looking at change in baseline in visual acuity score over week 60 and 64 in 545 patients. And Pavilion is looking at diabetic retinopathy without edema that involves the center. And the 2 arms are looking at the PDS implant with set refills as compared to clinical monitoring. And the endpoint is going to be the percentage of patients with a greater than 2-step improvement from baseline on the DRSS score at week 52. So another innovation is looking at medicines that are already approved, but given in different doses. So high dose aflibercept is a good example. Part of the rationale for sort of looking at this is that higher dose aflibercept, including the 8 milligram dose, should provide a longer half-life and allow the medicine to work for longer. So Photon is a phase 2/3 study that's investigating the efficacy of the 8 milligram dose compared to the approved dose. And the target population is diabetic patients. So there's 2 experimental arms looking at the 8 milligram dose, either given every 12 or 16 weeks, and they seek to enroll 640 patients. And then separately, gene therapy is also being investigated. We talked about it a little bit earlier in DME as well. So ADVM22 is a AAV vector that encodes a coding sequence for aflibercept that's given via an injection. Phase 1 data was promising, and so the Affinity study is a phase 2 study looking at DME. As we talked about a little bit earlier, unfortunately, the company announced that there was an episode of a patient developing panuveitis and vision loss. So obviously, more investigation is needed regarding the safety of this. RGX-314 similarly is gene therapy, which is an AAV vector that's used to deliver a gene encoding an anti-VEGF antibody fragment, but rather than given via an injection, it's given surgically. I had the chance when I was a fellow at Wills to watch one of my mentors do this surgery. Again, I'm just having some trouble seeing the video. So in order to do this surgery, obviously the vitreous is first cleared out. And this surgery, I think, is a little different than typical surgeries that we do as retinal surgeons. But in order to give the product into the subretinal space, use a 41 gauge cannula, first testing outside of the eye, and then creating a small bleb that we placed outside of the macula to be able to deliver the medication underneath the retina. Great. So the Altitude study is looking at NPDR and NPDR patients with a goal enrollment of 40 patients, and the primary endpoint will be improvement in DRSS at week 48. In conclusion, there's multiple ongoing studies in phase 2 and 3 looking at diabetic retinopathy and DME. And there's really multiple avenues in which these entities are being attacked. So looking at novel therapeutic as well as established drugs that are given in different ways, and then gene therapy is obviously being investigated as well. So hopefully these will revolutionize the way that we treat diabetic retinopathy. Thank you so much.
Thank you, Kat, for that really informative talk. I look forward to speaking with you more at the panel, and again, reminding everyone to please put some questions in the chat, and we will get to them for Dr. Talcott. Our next speaker needs no introduction. It's one of our chairs of the Retina Summit, professor of ophthalmology here at the Lerner College of Medicine. One of my partners, good friend, Rishi Singh. Rishi is going to talk to us about applying DRCR network protocols to clinical practice. Rishi, take it away.
Thanks, Anil, and thank you for all watching at home. This is a talk that will summarize some of the DRCR retina network protocols and how they apply to us every day with our patients. And here are my financial disclosures for the presentation. So the key point is that the DRCR retina network, we really owe a debt of gratitude to all the work they've done in the past few years. They've discussed numerous topics regarding diabetic retinopathy, and they're going to be obviously embarking on some future protocols addressing other causes of blindness in the US. And this is just a sense of just the scope of what they've completed. And this is an older slide. This actually goes just till 2019, but they've completed even more since then. And you see just the depth and breadth of all of the trials that have been done, both using laser, anti-VEGF, even discussion in the office with the provider to see if it lowers hemoglobin A1C. That was actually a study that they performed. The end result of that, it didn't matter on the finality of the A1C change for the patient. But they had some really impactful protocols in the past few years that have changed the way we handle patients. And in addition, they're coming up to being many more protocols that are going to have readouts soon. Here are just a few of them that they're undertaking an enrollment currently, which are going to help us better guide our patients through these processes. So let's start off with protocol I, and this obviously was a comparison of ranibizumab with prompt or deferred laser alongside triamcinolone for the treatment of diabetic macular edema. Patients were receiving the anti-VEGF on an as-needed basis. One of the interesting findings, obviously through the study, has been that prompt or deferred laser in the study was equivalent with regards to visual acuity. And the number of anti-VEGF injections went down precipitously as the years went on. And that was an interesting finding because I think a lot of us thought that the diabetic macular edema population is one you're going to have to continually inject over time. And yet this study really showed that there was a downstream effect where really the vascular is already stabilized And by year 4 and year 5, you're only giving between 0 and 1 injections over that period of time. One of the other interesting analyses that was done here was the analysis of patients that essentially had poor or limited response after 3 anti-VEGF injections. And this study was a post hoc analysis that's been looked at and essentially found that patients stayed in these quote unquote swimming lanes if they had a poor response after the 3 initial injection periods over the course of 12 months. And in fact, when you look at this data from Protocol I and compare it to some of the more recent trials, and this is some sub post hoc analyses that I performed both on RISE and RIDE and VIVID and VISTA, you see that the swimming lanes actually don't exist with increasing the number of anti-VEGF injections. So therefore, this idea that you had these swimming lanes in Protocol I really can be ameliorated and broken through if you give additional anti-VEGF injections as they gave in RISE and RIDE and VIVID and VISTA, in comparison to Protocol I, which is a PRN-derived treatment. Now, one of the other exciting areas of anti-VEGF use is in and around the treatment of patients with proliferative disease. And here you can see a patient on the initial examination with areas of proliferation present in the mid and far retinal periphery. And after a single anti-VEGF injection, they have a lot of vascular stability. So really impressive results. So how do we handle patients now with or without with or without diabetic macular edema in the setting of proliferative disease? And Protocol S was a study that looked at this and importantly looked at 5-year outcomes of these patients over time. Patients were randomized to receiving either panretinal laser or anti-VEGF injections for the treatment of proliferative disease. They could not have a history of PRP prior, and they could have either center involving DME at the time of randomization. And what the study found essentially was that if you treated the patients with PRP, you had to look to make sure, obviously, that they needed additional treatment and applied additional PRP. For the patients who received ranibizumab, they received 4 upfront injections, and then afterward PRN treatment thereafter, again, based upon the clinical exam, which looked at the presence of neovascularization to determine treatment response. Here's the study completion rates, which are really quite good for a DME study over a 5-year period with 60% retention over that trial period for both arms. And what they essentially found at the time of enrollment was that high-risk PDR to advanced PDR was seen in a proportion of patients, but mild to moderate PDR was seen more commonly in those patients. And a lot of patients had ranibizumab at baseline because they had center-involving DME with the associated visual acuity loss. So this was not really a pure trial, but it at least showed that in patients with baseline DME, that there was a significant proportion of the population that improved with anti-VEGF injections and had sustained visual gains over that 2-year period in comparison to those patients who had PRP with anti-VEGF given as needed for the DME alone. On the right side, you see actually the results of those patients without baseline DME, where you can see basically they're equivalent with regards to visual acuity during the 104 weeks of the study. So the 2-year outcomes showed for the anti-VEGF treatment, in this case ranibizumab, superior visual acuity outcomes over the course of 2 years, less peripheral visual field loss, 3-fold decreases in vitrectomies, the decrease in development of center-involving DME, and it's cost-effective when DME is present, causing visual impairment. And the other side of the coin favored PRP because it had fewer injections, fewer visits, and it was cost-effective when DME was not present on presentation initially. And here you can see the number of injections over 5 years given again for those patients here. And I think the important takeaway here for anyone watching this program is that people feel like PRP is a definitive treatment. You can see clearly here that patients in the first year received 2 treatments. Year 2 received an additional potential average treatment. And even in year 3, 4, and 5, some of them got additional PRP treatments. On the anti-VEGF side, the same was true. But I think the point here is that there were a lot of injections given and still a lot of laser given, despite the fact that they initially received laser within the first year or 2. In addition, those patients received additional PRP in the anti-VEGF group, but for very low numbers. Only 14% received it during follow-up versus the PRP group over time. And again, if you look at the time out to 5 years, you see the mean improvement in visual acuity is equivalent in all of these groups. And again, the visual fields were statistically different at year 5, favoring again those with the anti-VEGF arm in comparison to the panretinal laser treated patients. One of the other things, obviously, is that in 5 years of treatment, those in the ranibizumab arm actually had a 2-step improvement in DR severity of about 46%. Obviously, this was not capable or achievable in the PRP group because that does not change, obviously, the level of retinopathy. And importantly, I think the adverse events, the vision-threatening retinopathy complications were really quite similar between these groups. So these both treatments are effective at reducing these VTRs over time. So at 5 years, many of the conclusions were still the same. Both groups had very insubstantial amounts of patients who had vision loss. And again, the visual fields were quite different between these groups. And the conclusion should be, again, when DME is present, anti-VEGF should be given alongside PRP. And those patients actually with anti-VEGF alone had superior visual outcomes than those who had PRP alone. And again, in our true practice, this is really a blended approach with using both anti-VEGFs and PRP for these approaches. I'm going to briefly summarize Protocol T because you're aware that this was the first comparative effectiveness trial for DME patients. And the patients in this trial outcome were allowed to compare between aflibercept, bevacizumab, and ranibizumab during the course of the study. Overall, at 2 years, again, this study showed that the patients in this group were superior in those who got aflibercept in comparison to ranibizumab and bevacizumab. And in addition, the visual outcomes were the same in those patients, especially with 20/40 or better vision. But in those patients who are 20/50 or worse, you had a significant visual gains in the aflibercept group in comparison to the other two groups. And when you see the stratification by visual acuity, you see those in the aflibercept arm had a much greater visual gain as you went out as far as the visual acuity goes in comparison to the other two drugs as well. So at 1 year, each of these drugs was considered effective for DME treatment, but obviously Protocol T showed that aflibercept was superior when 20/50 visual acuity is worse. But I think the other important point is when 20/40 vision is better, you must look at the central subfield thickness. And this was a post hoc analysis which found that and looked at this and also found that when CST was greater than 350 microns, that both the branded drugs actually did better than those that was the non-branded drug, in this case, bevacizumab for Protocol T. So it's important to make sure you look at the central subfield thickness, even when visual acuity is 20/40 or better, because that might indicate a superior outcome with some of the branded drugs versus the non-branded drug. Again, Protocol V was another trial that looked at good visual acuity in these patients, either with prompt anti-VEGF treatment or deferred anti-VEGF treatment for 20/25 or better visual acuity. It found that essentially all of these patients did equivalently better if you did prompt or deferred anti-VEGF for these patients over time with the same level of retinal thickness and maintenance of visual acuity. So again, only if visual acuity worsens should you start anti-VEGF in this population of patients. Again, some of the limitations to this study, you had a limited timeline of 2 years, healthy patients with a hemoglobin A1C of 7.6, and really motivated patients with good follow-up, which I think is different than what we have in practice. So again, I think that the important things to consider here are who you should potentially start patients with Protocol V treatment in 20/25 or better. Those who had 10 letters of vision loss, essentially those patients who had baseline CST of greater than 300, eyes with baseline diabetic retinopathy severity of 47 or worse, so severe non-proliferative disease, and the non-study eye that had a fellow eye having DME treatment was at a almost 2.5 greater rate of conversion. So that's important to, again, determine that from the study. So again, to talk about the DRCR Retina Network, you can't do it in a short time. I've already exceeded my time today, but it's really expanded the scope of all the retinal diseases that are being looked at. It is a nice infrastructure with rigorous scientific protocol development, and there are many, many ongoing trials available right now. And again, we owe a debt of gratitude to the work they've done, and Dr. Martin and Dr. Jennifer Sun, who have led their efforts in the recent years. Thank you.
Thank you, Rishi. A great talk. Looking forward to the panel where we can discuss this further, and you're never over time, my friend. You can take as much time as you want. It's my pleasure to introduce our final speaker for this session, Christina Wang, who's an Associate Professor of Ophthalmology and the Director of the Vitreoretinal Fellowship Program at the Baylor College of Medicine. Christina is going to talk to us about treating diabetic retinopathy with anti-VEGF. Christina, welcome, and we look forward to hearing your talk.
Thanks so much for the introduction, Sunil, and thank you to you and Rishi and Peter for the invitation to join you at the summit this year. It's a great meeting that I've attended since I was a fellow, so I'm thrilled to be here. And I'm also thrilled to be talking about a topic that's rapidly evolving in our field, which is the use of anti-VEGF in treatment of diabetic retinopathy, both in its proliferative and non-proliferative forms. These are my disclosures. So let's start off with a real life example. This is a patient that walked into my clinic a few months ago, 20/20 asymptomatic, but clearly, as you can see, has high risk PDR. And if I throw out the question to the group for how you would manage this patient, I bet you that in this virtual room, there would be a number of different responses. And that's because there really essentially are 4 viable options today that exist for PDR management. And those include PRP, anti-VEGF, a combination of PRP laser and anti-VEGF, and of course, surgery for our most advanced forms of PDR. And when I'm trying to sort through how to treat each patient that I see, how do I choose which option might be best for them? I really think about 3 phases of PDR. And those would be active NV without vitreous hemorrhage with or without a view, and tractional retinal detachment. And I'll discuss a little bit more about how I apply the current data that we have to these different phases of PDR a few slides down the road. But first, I want to touch on a couple of very important studies that give us scientific evidence for using anti-VEGF in the realm of PDR in the first place. And Rishi just covered these really nicely, so I'll go through them very briefly. But Protocol S from the DRCR Retina Network randomized almost 400 eyes with PDR to either PRP laser or ranibizumab. The primary outcome here was the mean visual acuity change at the 2-year time point, and they found that ranibizumab was non-inferior to PRP. Additionally, several secondary outcomes also favored ranibizumab over PRP, such as visual acuity area under the curve, visual field sensitivity, and the development of DME. And around the same time, there was another study out of the UK going on called Clarity that also showed similar findings when they compared aflibercept to PRP. And again, the mean visual acuity change at the 1-year time point suggested non-inferiority of aflibercept compared to PRP. But what about Protocol AB? Protocol AB was published just last year, actually, in JAMA, and they drilled down a little further. They looked specifically at vitreous hemorrhage from PDR and compared the outcomes of patients who were initially managed with aflibercept compared to those who were initially managed with vitrectomy and endolaser. The primary outcome here was mean visual acuity area under the curve letter score between 1 and 100 over a 24-week time course. And the study was powered to look at an 8-letter difference, and they found essentially that there was not a statistically significant difference between the aflibercept groups and the surgical groups. Additionally, over 2 years, approximately 1/3 of eyes in each group received the alternative treatment. So 1/3 of the patients who were randomized to aflibercept ended up getting surgery. 1/3 of the patients who received vitrectomy ended up needing aflibercept during that 2-year period. Endophthalmitis was observed in 3 eyes, 1 in the injection arm and 2 in the surgical arms. So taking all of that data, how do you apply it to everyday decision-making? Well, again, going back to the 3 phases of PDR. For active NV without vitreous hemorrhage, I think Protocol S really nicely shows us that anti-VEGF and PRP are both reasonable options. And like Rishi said, they can be used jointly, and we do that all the time in the real world. But one thing I want to point out is that patient compliance has to be considered in making this decision. We know from the 5-year data in Protocol S that almost 1/3 of eyes, shockingly, still had active NV, regardless if they were in the ranibizumab or PRP arms. And then looking at this FA that I've included here, anti-VEGF, we know, can make neovascularization regress very quickly. It's super impressive, but just as quickly as it can go away, it can return as well. And we know from studies like Obaid's study that patients with PDR who are lost to follow-up, not an uncommon thing in this population, they fare worse if they were treated only with anti-VEGF monotherapy versus PRP. So something to consider when you're making your decision. What about vitreous hemorrhage with or without a view? Well, Protocol AB shows us that anti-VEGF and pars plana vitrectomy with endolaser are both reasonable options. Both of them have pros and cons. One of the benefits of surgery is that it can facilitate a faster visual acuity recovery, as suggested by the 4-week outcomes in Protocol AB. You can see here that the 4-week mean visual acuity letter score was almost 10 letters higher in those that received surgery compared to those who received aflibercept. And that really makes sense to me because you're actually going in there, mechanically moving out, removing the blood and the opacities. But there's other factors like chronicity, vitreous hemorrhage density, patient compliance, vision in the other eye, and surgical candidacy that should be considered. And again, one more real life example to the right there. This is a patient who had been treated at an outside hospital with serial anti-VEGF for vitreous hemorrhage, got lost to follow-up for 8 months, and then came to me. And you can see there that for that 8 months where she wasn't receiving any treatment, she's had some untoward events here. She's now developed a very nasty macular involving tractional retinal detachment. And finally, when you have proliferative membranes, as you see in this very aggressive tractional retinal detachment here, there's only one choice. You're going to go to the OR. But that being said, anti-VEGF can still be a remarkably helpful perioperative adjunct, and I love using it in these cases before surgery. Not only can it help differentiate the planes to make dissection easier, but probably more importantly, I would argue, is that it helps achieve hemostasis intraoperatively. And as a surgeon, everyone knows that for these cases, that can make or break you. I do try to follow the mantra of taking the patient within 7 days of their preoperative anti-VEGF, because even though there's some controversy around it, I do think that there's a theoretical risk of crunch, even though it's rare. And then in my last 2 minutes, I want to switch gears and focus on the use of anti-VEGF for non-proliferative diabetic retinopathy, an area that's much more in its infancy in the retina world. I think there'd probably be a lot less dissension in the virtual room if I asked what everyone would do for this patient here with severe NPDR, because most of us are still observing this condition at this time, but there's a growing amount of evidence to suggest that anti-VEGF ought to be considered in this disease state. And I want to focus basically on one important study that just was published last month, and that is Protocol W from the DRCR. This study compared aflibercept versus sham in patients with moderate to severe NPDR, DRSS levels of 43 to 53. The primary outcome was the 2-year probability of developing DME with vision loss or PDR, and it was reduced. That risk was reduced by nearly 3-fold in the group that was treated with aflibercept, as you can see in the graph to the top right. However, there was no difference in the mean change in visual acuity from baseline to 2 years, and there were 3 cases of endophthalmitis, all in the injection arm. Of course, it's also important to mention a similar study called Panorama, which I'm sure everyone has heard of. Panorama showed similar findings in comparing aflibercept versus sham for DRSS scores between 47 and 53. And if you look at that bar graph to the right, you can see that treatment with aflibercept every 8 or 16 weeks, as you can see in the blue and the purple bars, led to a much greater chance of a 2 or greater step improvement in DRSS levels compared to the sham counterparts. So again, how do I apply this to everyday decision-making? It's a little trickier here because the use of anti-VEGF in NPDR is much less well-established. But I would consider it for patients who've had aggressive contralateral disease at this time. I think most of us are really waiting for more data, and there's a lot of unanswered questions. For example, does phenotypic improvement, as you can see what happened to my patient down below, does phenotypic improvement really amount to true disease modification? That is an unanswered question as of yet. Additionally, we're all awaiting the Protocol W 4-year data because we really want to better understand the visual impact, which is ultimately what matters to the patient. And Kat really nicely covered some of the longer acting anti-VEGF therapeutics, some of which are very close to the end of the pipeline. And I think those are really key when we're discussing potential treatment of NPDR in the future, because addressing the durability issue, I know will make us more receptive, at least, to the potential of treating earlier in the diabetic retinopathy disease course. And that's it. Thanks so much. Look forward to the panel.
Thank you, Christina. Great talk, and I'm going to welcome our panelists here to discuss some of the questions from the session. Also welcome Yasha Modi. Yasha just decided to show up, so we're include him in our panel just to talk. So fantastic talks. Let's start off with a question from the audience. This is actually directed to you, Christina. Yeah, do you perform anti-VEGF to all patients with tractional retinal detachments with active NV with and without vitreous hemorrhage? And is there a worry about worsening outcomes secondary to crunch in cases where patients don't present to their scheduled OR day?
Yeah, that's a very pertinent question because I spend half my time at the county hospital where we have very advanced disease. And so we're faced with that question a lot. I would say that I don't do it for everybody, every TRD. I don't apply this universally, but I do it by judging how much vascularity there is. So if it's someone that I showed you in that picture who has a ton of active vessels that you know are just going to cause a huge bloodbath in the OR, I definitely do treat them. And I explain to the patient that it is very, very important for them to make sure that they can come. If I think there's any question that they're not going to show up, then I agree. I think they're, you probably are best holding off, because I do think that the risk of crunch, although it's debated by some, I do think it's a real risk, albeit small.
Great. I love further perspectives. I think it's something we all talk about and deal with. So let me go around. Yasha, since you're jumping in, I'd love to hear your perspective on it. What do you think? What do you do?
Yeah, I think Christina, that was just a great talk. Great talks all throughout the session. This is a complicated situation. I don't think we have like really strong level of evidence guiding our decision making. Rishi, when I was a fellow, used to, or probably still does, give serial anti-VEGF injections. So while we always sort of say give it within 7 days and then go to the OR, Rishi has in his mind that he's going to the OR no matter what. These are maybe people with posterior hyaloid traction or where the fovea is attached. And he'll do 3-4 rounds of anti-VEGF. And what I've learned from him in this is that with progressive PRP, progressive anti-VEGF therapy, we get progressive hyaloid separation, and that actually makes the surgical case much, much easier than in those cases where the hyaloid is plastered down. So I'd love to get Rishi's input here as to what he's still doing.
Yeah, I still do
yeah,
that. Yeah, it's a great technique. It works really well. I don't think there's any worrisome issue in delaying surgery for, a month or two for some of these fractional diabetics. The fluid and their photoreceptors are much more tolerant to eventual treatment. A lot of these patients ultimately, even despite our best efforts, lose vision from macular ischemia, not necessarily these tractional detachments per se. And so it's really interesting. It's a great way of treating the patients. The one thing I've been cautious about recently, as I've seen more and more patients come back from the pandemic after not being treated for 9, 10, 12 months, is I'll inject and then I'll see them a month later and their tractional detachments have actually worsened significantly. I'm going to the OR anyway, it doesn't really matter, but I've just been impressed with that thought process around crunch and seen it much more frequently recently. And I don't know why, but it appears to be quite aggressive in those patients. And regardless, the point is it's fibrovascular tissue is now gone. You have an easy approach, much easier than you would have done if you would have gone the first time around.
Yeah, great points. Let me hit some of these other questions just for all of us. One of the questions that's to the panel, and severe NPDR. Do people treat these patients? So let's take it from the question specifically has to do with an accounting setting with somebody who has maybe poorly controlled diabetes. Do you consider preemptive PRP? So, Kat, I'm curious, what do you do in your scenario when you have a patient who has severe NPDR? Are you considering anti-VEGF therapy on those patients? Maybe it's someone who doesn't follow up as great. Do you ever do PRP in those patients ahead of time?
I think it's a really good question. And I wish we had more data in this area to sort of guide us. But obviously, even if we had the data, you really have to consider the person in front of you. Like Rishi, I've really seen an explosion of people's diabetic retinopathy since the pandemic happened. And, I'm really, I think, concerned in these patients because they have so many other medical conditions about them being lost to follow-up. Currently, I don't treat severe NPDR patients with injections, but what I definitely do in all these patients is I get a wide field FA, and I'm really looking for any sort of signs of neovascularization, because I think if you look clinically at these patients, it will often look like there's not any NV, but you'll be surprised what the fluorescein shows. Obviously, in special situations, if patients have lost vision in one eye or they have an advanced CRD and I don't think their visual potential is very good, and I'm seeing any hints of sort of neovascularization, then I definitely have a low threshold for putting in PRP. It doesn't need to be sort of very aggressive PRP that goes right to the arcades, but I think getting some PRP in these patients, no one ever regretted that, I think, as a clinician, getting that laser in.
Yeah, so growing up in a county hospital with my residency, I tell you, this was the reason we PRP'd. I still believe in it. Mark, I'm curious your thought process. What do you do in this scenario? Severe NPDR, maybe not so great follow up. And uncontrolled diabetes. Are you lasering them earlier? Or are you watch? How do you ensure compliance or try to improve compliance?
To be honest, if I even think that compliance might be an issue, maybe based on prior experience with a patient, then I might add a light PRP. I mean, there's little downside to that. There's more downside, as I think I have to echo what other people in front of me have said. People are coming back and their traction detachments are just nasty. And I have some people that were controlled in every 3-4 month anti-VEGF, and they're coming in 8 months, a year later, and I'm kicking myself for not having laser done. Now, who knows, would it be drastically different? But that's one thing I'm always thinking about. So I'm fortunate not to be in a county setting, but having been in a setting like that in the past in my training, yes, my threshold for laser was lower. My threshold for laser was lower.
No, I'm happy to say that, you know, at our county, we were doing this, we were putting PRP in, and now we're seeing some of these patients back. And, you know, as I tell all the fellows, I've never regretted laser putting it in too soon. And I think we've saved a few eyes, hopefully. Let's move on to severe NPDR. Sorry, let's stay with severe NPDR for a second. Christina, what's your endpoint with anti-VEGF? That's one of the questions from the audience. So do you have a specific endpoint you're looking for?
I mean, I think that's one of the million-dollar questions, and we can't answer that until we truly know why we're treating and what the goal is, right? So we haven't seen visual acuity benefits yet in our few studies that we have, but you know, to kind of expand on that a little bit more, I think there's also a real question of whether we're truly modifying the disease. So yes, the pictures look better, the fundus, you know, you don't see hemorrhages, and you can see the remarkable improvement in a lot of patients that we're treating. I see this all the time in my DME patients, but does that ultimately change their risk for, you know, vision threatening complications? Is that going to help them preserve vision? And until we know that, I don't think we're going to know what that endpoint is, Sunil. And I will say that that's one of the parts that I'm hesitant about in starting to treat these a little bit earlier is, you know, are they going to need these injections forever? And it seems like they might, you know, and so you've got to really take that in consideration when you've got patients who are already less compliant. They're not really going to feel any sort of benefit. And you've got to take all of those factors into account.
Yeah, great point. And Yasha, I know you want to say something. You're muted, but you can unmute yourself. I'm going to ask you this one. You can answer at the same time. Somebody asked it in the chat, and it was provocative, and I was going to ask this. What about the role of early vitrectomy in these patients? So Yasha, you can say what you were going to say. And would you ever consider vitrectomy in some of these patients with severe NPDR? Is that something we should consider?
Yeah, before I get into that question, I just wanted to follow up on one point for Christina, because Roger Goldberg from the Bay Area actually looked at a post-hoc analysis of Rise and Ride. And what he looked at specifically was the extension study where people weren't getting as frequent anti-VEGF therapy. And what he realized is that while individuals who had excellent regressions in their diabetic retinopathy while they were in the clinical trial, in the extension study for patients who maybe had severe NPDR and then went back to mild NPDR, their progression back to severe NPDR was way faster than what we would physiologically expect from going to mild to severe. And this really highlights the fact that maybe, as Christina had very eloquently put it, we're probably not modifying the disease process by anti-VEGF, but maybe masking it. And that also highlights the fact that we may need injections kind of in perpetuity. And Protocol S 5-year data, people were still receiving injections 3 times a year. So it wasn't like it dropped down to 0. So, and then as for vitrectomy, I think, you know, this is sort of a long debate as to, you know, I think this is about risk modification. We think we're really great surgeons. We'll just lift that highlight. It'll be like no big deal. And then all of a sudden you realize there are all these plaques of neovascularization that maybe you didn't realize because you didn't get a wide field FA. And it becomes a really, really hard surgery. And you may take a 20/20 eye, and the reoperation rates that have been previously reported have ranged anywhere from about 5 to 10% all the way up to 25% with significant posterior highlight traction. So I think picking your candidates wisely is really important there.
Yeah, I think great point. And I don't think attendings need to start drinking more, doing 20/20 eyes with severe NPDR and doing a vitrectomy on these patients. Hey, Mark, let me ask you a little bit, switching gears, staying with kind of like the severe NPDR, but maybe adding DME here and talking about when you have somebody who's harder to treat. Let me hit you up here with the idea of adding steroids. You know, does the is there a difference in your mind in phakic or pseudophakic patients, how you address the patients who maybe are anti-VEGF resistant? Do the visual acuity results in your mind change when they're phakic? I mean, do you counsel your patients a little bit more that they're probably going to drop a little bit of vision with the cataract? Does that play a role in what you're doing next?
The short answer is no. But I do talk to them saying, look, the cataract will progress faster. Maybe not with the first injection, but once you go down that path and you see some efficacy, and I'm a big fan of steroid, to be honest with you, then chances are you'll need multiple injections going forward. But I think nowadays, cataract surgery is so advanced. Yes, it is an issue, but is not. I'd rather treat the DME because that's long-term vision loss as opposed to an inconvenience. I'd be more worried about the glaucoma factor, to be honest with you. But again, usually treatable with topical medications. So our job is to balance the risks and benefits for our patients, and the risk and benefit profile for steroid is different, but it's in my mind acceptable.
Rishi, do you do any micropulse laser in these, like maybe resistant patients, or do you ever do focal laser still in some of these patients? What's your practice pattern with laser at this point?
Yeah, it's when I do a focal laser, it's like I'm splitting an atom in clinic, because people walk around and they're just excited to see a focal laser being done. I do it every so often. I mean, I think it's helpful, especially when it's non-foveal involving DME, which is still clinically significant macular edema, right, by definition standards. But I echo Mark's opinion. I think we have enough efficacy in our anti-VEGF, but also in our steroids, which don't get used nearly as much as we probably could use them. These drugs, especially drugs like dexamethasone and the fluocinolone implant, are wonderful, and the post-hoc studies, the phase 4s, show a much better safety profile than have been shown in the past. I think because the phase 3 trials were just poorly designed, and they were in an era where you had a lot of dropout and a lot of obviously phakic individuals weren't the right individuals to have in the population. So clearly, there's a lot of data we could gather from user and Paladin and other studies that come out that have really just helped me do that. The problem is the kinetics are very different in those drugs. Ozurdex has a really quick down, but really rapid up. So the variability in OCT is significant. It's about 475 to 100 microns. In addition, even with the fluocinolone implant, I find the kinetics to be a little bit slower than I would like. So you wonder what effect that has long-term in the patient, albeit steroids, no one doesn't respond to a steroid, let's put it that way.
Yeah. Kat, let me ask you, have you, so along those steroid lines, actually a two-part question. One of them is from the chat on how long it takes to implant a PDS. So that's one. But a second one, we've heard about steroids and using it for diabetic retinopathy. Any role in your mind of combination therapy earlier? Should we, as like in treatment naive patients, and some of these patients maybe have like 850 microns, do you ever put in steroids and anti-VEGF? So I'll give you both questions together.
So first on the anti-VEGF and steroid question, I think that's a really good point. I have not done that before. I usually still treat with anti-VEGF to see what kind of response I get. And I feel like if I'm not getting that much of a response, then I'll switch over to steroid. But I think, as other people in the panel have mentioned, I think we should overall be using probably more steroids than we are. If I've looked back on patients who I've eventually switched over, I do kind of look back at their OCT and I was just like, maybe I should have switched back before. So maybe there is a role to doing it sort of upfront, but often I feel like with these patients in general, it's really important that you establish a good rapport with them. And I think we're very comfortable using anti-VEGF options, and we talk about sort of the risks. I do worry that sort of starting off with a steroid in some patients, sort of going over the more complicated discussion about the risks can turn some people off. And so I usually try and establish a rapport and then see what kind of response I get to anti-VEGF and then switch over, even if I see the OCT at the beginning and I was like, I think this person's probably going to eventually need a steroid, but it's definitely something to think about. And then your second question about PDS, we've done a couple of these at Cole. I think our surgeries have taken about 45 minutes or so to do each. I think, once PDS sort of hits the market, I can see it. I can see that changing a little bit. I think once you get more comfortable doing that type of surgery, I think that time is going to go down. But, obviously it's a novel surgery. It utilizes some techniques that I think we're not used to in terms of the scleral dissection all the way down and doing the laser and just making sure that everything is okay with the port. So I think that with time, that'll get more efficient. The other thing that I think might be interesting is I know that the refills are done in clinic, but those I think can be a little challenging in some patients. And, obviously things are done as part of the study, but it might be sort of interesting once PDS gets approved for more challenging patients. That might be a procedure that might be done well in the OR under local anesthesia rather than in the clinic. So it'll be interesting to see what happens as the technology evolves.
Gotcha. There is a huge demand for us to address micropulse laser. I'm getting like three or four questions about it. So let me ask the panel, anybody do micropulse laser? Anybody have think there's a role for it? Yasha, are you doing micropulse laser, yes or no? Any role for it in your mind?
I've tried it a few times when we got a micropulse laser. I just wasn't all that impressed. I didn't know what my endpoint would be, and I think I'm just, unfortunately, I use it so infrequently, I'm not like qualified to make a judgment call on it.
Okay. Mark, how about yourself?
Don't use it.
Okay. And Christina, any experience with it? Any opinion on it?
I haven't used it either, Sunil, and I feel like the data is mixed. I haven't been convinced yet.
Kat, and then I'm going to give the last word to Rishi on that one.
I haven't used it. I remember during fellowship watching some of my attendings use it, and I think like other on the panels have echoed, if you're not using it all the time, it's a little unclear what the endpoint is. I think Rishi made a good point earlier, though, with focal, like laser in general, we have to keep doing these things. If we don't use them, we're just not going to use them. It's much easier to do an injection than it is to do this nebulous treatment that we don't feel as comfortable.
Rishi, your opinion on it?
Ouija board works just as well.
All right, thank you. Let's move on to the next question here. There was a question about essentially getting treatment approval for aflibercept in patients who have diabetic macular edema, pretty thick retinas. Has anyone had any difficulty in getting getting this approved as primary therapy? Or has everyone had to use essentially treatment failure with bevacizumab first? Rishi is shaking his head yes. So Rishi, your experience, or can you make the argument?
It's a great point. The data is obviously there. They'll say this is a post-hoc analysis, so therefore, the problem I think we run into with all of this data is that when the DRCR develops clinical studies, they have long-lasting effects on lots of things, including insurance and payers and what they will do. And so I think it's an important point to consider that obviously this data I presented, which was the thickness data, is a post-hoc analysis and shows a difference there. So the study was not powered to show a difference, but still showed some difference, especially thicker retinas with good visual acuity, 20/40 or better. So I haven't run into the issue with payers as of yet. I suspect we will. They don't really look at the retinal thickness per se. They look at visual acuity, they basically look at DME, and they look at the diagnosis code, and they look at what you're trying to do from a CPT code, and then they deny it. So I don't think they've become that sophisticated to look at that, but eventually they will. And then we're really going to have trouble with some of the payers trying to get authorizations for that. At least in our area, we haven't had that issue.
Sure. Mark, how about your experience with this? Have you had to essentially fail bevacizumab, or have you been able to make the argument based on vision or thickness of going to first line aflibercept?
No, honestly, it really depends. Yes, there are some patients in which I first have to go through the process of step therapy. It's pretty random what different payers will decide is the appropriate failure. But yeah.
All right. Just back to the steroid question here for a second. We mentioned dexamethasone. Do people use triamcinolone as their steroid? Do you think the outcomes are similar? Yasha, do you have an opinion on triamcinolone versus dexamethasone and Ozurdex?
Obviously, I love the dexamethasone implant. I use it frequently. I do uveitis as well. But in Bellevue, our city hospital, I only have access to Avastin and Kenalog. And so I do use triamcinolone quite frequently in that patient population as well. There's the rare patient who comes in with like Kenalog everywhere in the eye, like, the pseudoendophthalmitis, and that we worry about. And that's a little bit nerve-wracking, especially considering we have rotating residents who may have done the injection but then not present for the follow-up. But I use it. It works great. You know, obviously you have the same ocular hypertension issues. And for those patients, I tend to actually put them on prednisolone for 6 weeks before I switch. In my practice, I put patients on Durezol for 6 weeks before I switch to an Ozurdex, just to sort of mitigate that, to identify whether or not they're going to have an ocular hypertensive response before. So it's just one very easy quality control mechanism to sort of buffer against ocular hypertension response.
Great. Christina, I'll give you the last word on this. Any difference in your mind, triamcinolone versus Ozurdex?
No, I agree with Yasha. I'm in a very similar situation where at County, all I have is bevacizumab and Kenalog. And so we use it all the time and it's effective, you know, as all steroids are. It's definitely less predictable when you're talking about things like monitoring for IOP response. So I absolutely prefer dexamethasone for that reason, as well as the other reason that Yasha mentioned. I think that we have seen several pseudoendophthalmitis cases. They just throw a little bit of a wrench in your overall flow of the day. But we just had one last week. But you know, the things to look out for there are, you know, no pain, no redness or injection on the outside. And I agree with Yasha. I like to start aggressive topical steroids for that, and I think it, you know, cools down pretty quickly. So
great. Thank you, panelists. Fantastic job with this whole session. It was great talking to all of you. Thank you, Yasha, for crashing the party. I know you did this particularly to get the Grubhub gift card, which we're about to give away. You're not getting it, Yasha. It is $100. It's going to be sent over email. And I'm sorry, I'm pulling up the winner. It's Angela Wang or Angela Wang. I apologize. Congratulations. You'll be getting a $100 gift card to Grubhub. Feel free to buy Rishi and I an appetizer meal or, you know, some samosas. We are pretty flexible on it. We're going to go to our non-CME portion. We're going to have another break. This is going to be 7 minutes. I'm really excited to introduce our silver sponsors, both Chris Sims. Chris is going to talk to us first, and then Victor Perolath from Kodiak, he's going to talk to us as well. Please come back for our last session where we're going to be talking about imaging and surgery, and we'll take it away with our non-CME event. Thank you.
So we're back from the break. Thank you for all of you watching at home. And we're going to continue on with our presentations for the afternoon session. Our first talk of the afternoon session is actually by Yasha Modi. Yasha is an associate professor of ophthalmology at NYU, and he's going to speak on OCT and OCTA imaging and AMD and evolution in clinical practice. Yasha?
Great. Thank you so much for the opportunity to speak today. Let me see if I can advance my slides here. These are my financial disclosures, which are, none of them are really relevant to this talk. And just having a little bit of difficulty advancing the slides. So I just wanted to start with this case. So this is a 74-year-old woman, presents with decreased vision. This is not a diagnostic dilemma, but the question is, which images do you like to look at in order to make the diagnosis? And then the second question is, what images are necessary to make a diagnosis here? And when I think about this question, I say, well, what are my goals when seeing AMD patients? And if I try to distill this down into the simplest elements, the first bifurcation is obviously, is this wet or dry? The second is, what type of neovascularization? Is this type 1, type 2, or type 3? Because I think that adds a fair amount of prognostic value. And then if it's dry, is it really just dry, or is this neovascular non-exudative AMD? Because that also has prognostic value. And Dr. Kovac gave a really wonderful talk earlier today on some very similar topics. And, you know, when I was a fellow, I always sort of thought about the telltale signs of wisdom. And they always sort of started off with Dr. Martin saying, you know, back in my day, we just did it by hand. Back in my day, this didn't even exist. And I sort of think about I'm still waiting for that wisdom moment. When am I going to get that wisdom moment? And when we think about the AMD classification prior to the start of my training in 2011, it was pretty straightforward. We had non-exudative disease and we had exudative disease. And if we think about it, 10 years later, we still have all of the features of non-exudative disease, but now we have neovascular disease, and neovascular disease is now broken down primarily by OCT angiography into non-exudative and exudative disease. And then finally, when we think about advanced atrophic AMD, thanks to an OCT classification, that we can now break it down into whether or not there's complete or incomplete disruption of the retinal pigment epithelium as well as the outer retina. And it's important to realize is that over the last 10 years, all of these advances were driven by either OCT or OCTA. So let's just take a couple of steps back. We're going to review some concepts here that were presented earlier. OCT-based neovascularization types. Here we have a fundus photo. We have a FA demonstrating an occult lesion. And if we look at the flow overlay on OCTA, we see a fibrovascular pigment epithelial detachment with flow signal in it, and then a occult neovascularization. So this is whether using FA, this is occult. If you're using OCT, this is a type 1 neovascularization. Here's a type 2 neovascularization where we see this SHREM or subretinal hyperreflective material underneath the retina. We see some subretinal fluid, and this corresponds to a classic neovascularization on the FA. And then finally, if we look at a type 3 neovascularization, this is really, really hard to make just clinically. If you look, there's just a pinpoint area of hemorrhage, a pinpoint area of fluorescence, and oftentimes it's very hard to discern just by FA alone if this is truly a retinal angiomatous proliferation. But by OCT, we can see that there's intraretinal fluid, there's exudation, and this is classic for a type 3 neovascularization. So some years back, Dr. Freund looked at all of his patients who had early conversion to neovascular disease, and there were 260 eyes. Not surprisingly, type 1 neovascularization was the most commonly formed one at 40%. But what was surprising to me was that 1/3 of patients had type 3 neovascularization. So by OCT, there was certainly increased detection of type 3 neovascularization, which would have otherwise been frequently overlooked by FA alone. And you can say to yourself, well, why do we even care about neovascularization type? Aren't we just injecting? Aren't these binary decisions? And the truth is, I think that that's probably true, but there certainly is some prognostic value. And this also helps me decide what type of treatment paradigm I would like to employ in my clinic. So we know type 1 neovascularization, frequently better visual acuity outcomes. These are indolent lesions, but they may require frequent therapy, and we are able to extend the interval. And thanks to Bailey Freund, we now realize that these are likely protective against macular atrophy. So my treatment paradigm, and this is uniquely my own treatment paradigm, so I'm not trying to go and recommend a treatment strategy here, but I treat and extend these patients, and I'm tolerating but treating small amounts of subretinal fluid, and that comes from an extension of the fluid study that was previously reported. How about type 2 and type 3 neovascularization? Frequently, these patients have worse visual acuity outcomes, especially if type 3 is detected late. And that's one of the real beauties of OCT is to detect it earlier. They're high progression to geographic atrophy, and these patients are very responsive to anti-VEGF therapy. So how this plays out, for type 2, I tend to treat and extend these. And along with the lines of what Dr. Martin was saying, I do think that it's reasonable once we get out to every 12 weeks for a window of time, using the treat, extend, and stop study, we can consider potentially stopping these patients after a year. And for type 3 neovascularization, I start immediately on a PRN treatment. So this is a little bit more of a micro view to a lot of the treatments of macular degeneration where we're doing it by neovascularization type. So how about this patient? This is a case courtesy of Dr. Phil Rosenfeld and his fellow at the time, Dr. John Russell. And what we see is on OCT, this sort of double layer sign. And adjacent to it on either side, we see the classic drusenoid PEDs. And centrally, we see a much more heterogeneous material underneath the RPE. And if we look at these patients, we say, well, gosh, what is underneath that double layer sign? If we do an ICG angiography, we can see that there's this sort of plaque formation on the ICG. And if we correlate that with swept source OCTA, and yes, I agree that even though swept source OCTA is quite expensive, it certainly provides incredible, incredible detail of these neovascularization. And we can see flow in the area of this fibrovascular pigment epithelial detachment that corresponded to the plaque on the OCTA. And if we look, comparing the ICG to an OCTA slicing at the choriae capillaris, what we can see is this really beautiful complex of neovascularization. And remember, this patient has no exudation. And here's 20 months of growth over the course of this case. And we can see that these lesions evolve over time. They can grow. And here's a significant amount of growth over the course of 20 months, but there's no exudation. So these patients can remain stable for some time. But the question is, well, what's their natural history? And again, this was something that really comes out of Bascom-Palmer. Phil Rosenfeld has done a lot of the work. And here he's looking at 160 of his eyes, which he previously thought had to happen at either intermediate or advanced atrophic AMD. And by OCTA, he realized that 14% of patients actually ended up having some form of neovascularization. And of those patients, these were 15 times more likely to develop exudation. So we can extrapolate that thought process to, should we treat patients with neovascular non-exudative AMD? And this question was answered in the PROCON study that looked at 100 plus eyes that were randomized either to intravitreal aflibercept given every quarter or sham treatment. And what they had noted was that there was a significant rate of conversion to exudative AMD, whether you were receiving sham or aflibercept therapy. And so the conclusion was that there was no benefit from quarterly anti-VEGF because there was no statistically significant difference between these two. So we know the management of neovascular non-exudative AMD. At this point, there is no indication to inject until they progress to exudation. We should potentially observe these patients more frequently, and we can consider home monitoring devices as one option. And in conclusion, I think that OCT and OCTA have totally changed the way I practice AMD. And this may be, in fact, my first back in my day story. Back in 2011, I was taught to use OCT to confirm what I saw in FA and ICG. When I finished fellowship, I was using supplemental imaging to confirm what I saw in OCT and OCTA. And today I mostly just use OCT and OCTA. So thank you, and I'm happy to entertain any questions in the panel to follow.
Yasha, thank you for that talk. That's awesome. So for those watching, please put questions in the chat and we'll get to them at the panel. And so Yasha, just stay on for the panel discussion and we'll discuss the questions at that time. And so now we're going to turn over to Dr. Alex Yoon. Alex is a colleague of mine at the Cole Eye Institute, and he's going to discuss posterior segment trauma. Alex?
Thank you, Rishi. I'm bringing up my presentation here. Give me 1 minute. Okay, here we go. So we're going to switch gears a little bit now and talk about some surgery, posterior segment trauma, and hopefully I'll be able to give you some tips and tricks to help everyone with successful surgeries with, sometimes these very difficult cases. I have no financial disclosures. There are often some very unique challenges with these types of surgeries. The view is horrible, the anatomy is abnormal, and oftentimes there is some sense of urgency, for example, with intraocular foreign bodies and ruptured globes. So you need to be very flexible with your surgical planning and be ready for surgical surprises. The preoperative evaluation is very important in these cases. The clinical exam is often very difficult and is limited due to patient cooperation or lack thereof. So there are other modalities that can often help you before you go to the OR. CT, for example, I find is a very invaluable tool, especially in cases of intraocular foreign body. And CT can also be used to help you make the diagnosis of ruptured globes. B-scan ultrasound is important to help identify vital structures such as the retina or where the retina is most mobile. And if you suspect angle injury, UBM is of course very important, for example, in cases of cyclodialysis clefts. And always keep in mind that the primary goal of a lot of these trauma cases is the primary closure of the ruptured globe. The rest, you can come back and fight another day. So our first case is a 36-year-old MMA fighter who was hit in the eye during a fight. The ER physician noticed a gush of fluid from his eye. And you can see in this CT, he has an orbital fracture with a ruptured globe. And let's see, I don't see my video here. Okay, so in these cases with hyphema and dense vitreous hemorrhage, I like to use an anterior infusion and work my way back here. Oh, you know what this is? Yes, okay, yeah, in this case, after clearing the vitreous hemorrhage, this patient had a frontal retinal detachment with incarceration at the original rupture site. Shown here is the funnel after removing the anterior incarceration. And I like to use a bimanual approach here with a lighted chandelier. PFO, of course, is very helpful in these cases, but remember, you must remove all traction before completely flattening out the retina. Don't forget to look at the subretinal surface for traction as well. And then after removing all the traction, you can flatten out the retina. And in this case, we added oil, and the patient did well. I apologize. I think some of these slides are a little bit out of order, so I'm just going to move ahead. So that first video was supposed to play after these slides, showing the incarcerated retina. So let's just move ahead to the next case, who is a 43-year-old gentleman transferred from an outside hospital with trauma to his left eye. He was working on the deck, and a piece of wood flew in his eye, which he subsequently pulled out. His vision was hand motion. And in this case, we were pretty sure that he had a ruptured globe, so they had a CT, which showed a foreign body, a radio opaque foreign body medially, and also a high density material that looked like a hematoma inside the eye. We proceeded with the primary globe repair. A 17 millimeter corneal scleral laceration was discovered, and a vegetative foreign body was indeed discovered and sent for culture. The globe was repaired and a vitrectomy was performed. A total retinal detachment was discovered with a concern for choroidal hemorrhage. The posterior pole and macula could not be identified, so the case was ended, and antibiotics were injected. So this is just a reminder: if you can't safely complete the surgery, you can always close the globe and come back and fight another day. So after the primary globe closure, we were still not able to visualize the retina, so ultrasound was performed. And can you show the ultrasound here? So I like using dynamic B-scan because that really helps you make the diagnosis in a lot of these cases. You can see this cystic structure is a hematoma underneath the retina. So then we proceeded next with a secondary surgery. And can you show the surgical video here? So for the second surgery, we attempted first to complete the surgery without a penetrating keratoplasty, but as you can see, the view is horrible. So we had our cornea colleagues on standby. They placed a temporary keratoplasty, which of course gives you this amazing view, and we're able to then dissect out the vitreous hemorrhage. So I like to approach these cases in layers. You work anterior to posterior, taking one layer at a time, and once you gain good visualization of your retina, you can flatten out the retina with PFO. And here we've identified this hematoma. We can make a retinectomy and evacuate the hematoma and safely flatten out the rest of the retina. And in this case, we proceeded with a gas tamponade. So I'm just going to proceed with the last case here. We'll skip the pearls in the interest of time. I think everyone wants to eat lunch. Our last case is a 5-year-old boy who fell from his bed onto a broken glass cup with a laceration on the side of his face. We're unsure in this case if he had a ruptured globe. The exam was very difficult. So which diagnostic test is necessary? Of course, here a CT is very helpful, and you can see these shards of glass inside his eye. So we took the patient to the OR, first fixed the facial laceration, and then can we show the video? So in this case, the shards of glass are quite large. We had to use some unconventional tools, a hemostat here, to remove the foreign body. And as the glass was coming out, so were the ocular contents. So we used a escapement retractor here just to prevent the rest of the retina from coming out. I also like to, in these cases, use silk ties, just like a scleral buckle, for better control of the eye and to be able to fully rotate the eye for maximum exposure to the posterior wounds. And then after closing up the posterior wounds, we were able to perform a standard vitrectomy to remove the rest of the glass fragments inside the eye. In these cases, I like to enlarge my sclerotomy, but then place a temporary suture to help control the fluidics. And then when I'm ready to remove the foreign body, I remove the temporary suture and here pull out the pieces of glass from inside the eye. So we're able to remove all 5 pieces of glass, and I still see this patient, and he is doing well. And I'll take any additional questions or any questions during our panel. Thank you.
Great, Alex. Thank you very much for that presentation. And yes, we will get to questions, so feel free to keep filling up those chat boxes with the questions that we're going to get to in the panel discussion. And for the next talk, I'm going to turn it over to Dr. Justice Ehlers. He's Associate Professor at Lerner College of Medicine, also a colleague of mine at the Cole Eye Institute. And he's going to talk about the next generation of assessment of ultra-wide field angiography, opportunities for assessment of image features and disease activity. Justice?
Thanks so much, Rishi. It's really a pleasure to be here. I want to thank all of our speakers. It's been a great meeting so far. These are my financial disclosures here. We heard earlier from many of our speakers, including Christina, Rishi, and Kat, around some of the challenges with diabetic macular edema. This is an example here, and we often are treating based on OCT alone. There's significant macular edema. But one of the challenges that we face as clinicians is determining which treatment may actually be best. You know, we heard earlier about when do we switch to steroids or anti-VEGF, and there's more therapeutics in the pipeline. So we see that patient A and patient B may be dramatically different. And one of the potential opportunities with ultra-wide field angiography is to better understand the actual phenotype for the patients who are in front of us and to better understand disease natural history. And the angiography pan-retinal visualization really contains a wealth of information that remains untapped. Our current analysis is really limited to subjective interpretation of the clinician, and we have a limited understanding of what role potentially quantitative data from these studies could play in management of disease. So several years ago, we started looking at how we could move towards quantitative ultra-wide field angiography. And our initial platform was based on traditional image analysis algorithms. There were 2 time point assessments that we were looking at to evaluate dynamic features. And specifically, we were interested in looking at ischemia, at leakage, and at microaneurysms. And as we move forward with this, we've been able to potentially look at how this may be useful in various diseases. And I'm going to focus primarily on retinovascular diseases for the talk today. So we see here, this is an eye that's coming in with proliferative diabetic retinopathy, extensive leakage. We see peripheral non-perfusion here. And the question is, besides for saying, wow, this is really severe disease, are there opportunities to better characterize the actual phenotype of the patient in front of us? So this is some of the work that we've been able to look at in terms of being able to quantify some of the changes that we see in different severities of diabetic retinopathy. We see here, this is looking at total microaneurysm count, where we can actually look at differences between mild NPDR all the way to PDR and the changes that may exist and what these may be for biomarkers for treatment response and potentially prognosis. Similarly, we're able to actually quantify leakage index from mild all the way up to severe, as well as ischemic index in these eyes. So obviously, one of the real interests is, can we use these metrics in a clinical trial format? And we've looked at this in a couple of different opportunities. This was that same eye that we saw earlier, and this was a study eye at baseline. And this is after 6 months of aflibercept therapy. And as we saw in some of the earlier talks, the response is just tremendous. And the question is, can we actually quantify these changes in a way that are clinically meaningful? When we look more carefully here at baseline, we see these areas of leakage and microaneurysms. And one of the things that we may not recognize as readily clinically is that the microaneurysms are actually disappearing over time with ongoing anti-VEGF therapy. We can see that here. So instead of simply saying these images look tremendously better, we can actually say that this patient went from 354 microaneurysms at initial treatment down to 65 following 6 months of therapy. Similarly, when we look at an eye that had a baseline leakage index of 25%, we can look at their treatment response and actually quantify that they've dropped down to 3%. And finally, similarly with ischemic index, we see less dynamic changes as have been noted in many recent studies. And we've been able to look at this in multiple different studies, including a collaboration with Charlie Wyckoff's group, where the patients received monthly ultra-wide field angiography. And we had two randomized groups, one where we looked at this for treating based on diabetic retinopathy severity scale, and the other was treated based on leakage index changes. And what we found in this study was that both options were actually viable options for overall outcomes. But interestingly, the leakage index measure may actually be a more sensitive and earlier indicator of clinical worsening. And so when we look at these eyes of how frequent do we need to treat that, having a quantitative metric may actually be helpful. So what's the next generation analysis platforms that we may be able to see potentially in our clinics down the road? Well, machine learning augmentation is something that's gained a lot of interest across medicine, particularly in ophthalmology. And some of our newest systems takes into account multiple other important areas, including identifying the region of interest, even things such as optic nerve or artifacts such as the eyelid that we may be able to remove. And these are just some examples here of what we see of the deep learning output. The bottom row here is where, for the optic nerve detection model, where does it think the actual optic nerve is and being able to identify this? And this has specific implications for laterality, as well as classification of specific images. Here we see the deep learning output for specifically identifying rim artifacts or eyelid detections, as well as expanding into more extensive detail of leakage, for example, differentiating between perivascular and generalized leakage, and even being able to look at rate of leakage over time, as we can see here in this dynamic overlay. Vascular assessment is also something that may have particularly importance in terms of overall disease status, as well as disease burden. Multiple groups have shown that using deep learning augmentation may actually enhance our ability to identify subtle vessels. We can see here some of the work that's been done with our team using expert reader-based annotation to be able to actually enhance our visualization of retinal vessels in ultra-wide field angiography. So what does this take? So this is an example of the original angiogram. This is contrast enhanced. And this is what a reader did in our lab, actually looking at hand tracing these vessels. And when we do this at an extensive enough level to train a model, this is actually what you get as an output. So this is the machine learning output. We see just extensive visualization and details around areas of neovascularization and capillary dropout. When we apply this then to other conditions, we see here the normal eye, outstanding visualization of the retinal vasculature. It looks almost like an OCT angiography platform. We see here in proliferative diabetic retinopathy, the areas of neovascularization and capillary non-perfusion. In sickle cell, we see this peripheral vascular dropout as well. And this enables us to actually quantify these vasculature areas in unique ways. We can look at vessel area or vessel length, as well as tortuosity and some more advanced analysis that may have implications for outcomes. We see here we can look at geodesic distance, that is distances from areas of interest within the retinal vasculature that may have important implications for disease prognosis. We've also looked at specific local vascular density assessments in this density distribution and how the spatial relationship may impact overall outcomes. So how can we apply this clinically? We've looked at this in collaborations with Adrian Scott at Johns Hopkins for looking at sickle cell retinopathy and being able to monitor disease progression over time. We look at this for DR severity stratification using multiple different biomarkers and how this may change from normal eyes to more severe eyes. And we've even been able to look at this in predicting therapeutic durability. Eyes that when you extend out therapy in diabetic macular edema from 4 weeks to 8 weeks, differences in tortuosity that may have significant implications for how well a patient will tolerate that treatment extension. And we've also looked at this in underlying biologic phenotype, that the specific patterns that we see in the retinal vasculature that we're able to quantify may have the specific implications for the underlying VEGF expression or lower VEGF expression that might actually be more amenable to alternative therapies. Lastly, there's some practical applications of how we may be able to use this to actually quality optimize our early and late selection and do this in an automated way, being able to identify specific vascular area parameters. And as we can see here, the bottom line here is our optimized and automated selection of both an early and late image without any user intervention. So in conclusion, image-driven management of diabetic eye disease is really critical for optimizing diagnosis and management, as well as therapeutic decision-making. Quantification and potentially pattern assessment in ultra-wide field angiography may enable unique opportunities for personalization and precision medicine for the future. Our future work is really going to look at comparative assessment of our traditional modalities and traditional scoring systems and how angiographic severity may play a role, as well as detailed evaluation of some of these imaging biomarkers. Again, I want to thank everybody for attending today, and specifically want to thank my team and collaborators here at Coli and the Cleveland Clinic, and thank you again for your attention.
Great, thanks, Justice. And I'm going to welcome back our panelists for the discussion. We're going to skip Peter's talk, but we're going to talk about Peter's talk in this panel. So thank you for all of you who are watching at home, and we'd love to get to your questions today. So let's start off with the first question around surgery. Alex, you presented some stuff around trauma. This is one of the panelists, people watching at home. The timing of trauma surgery is something that we always struggle with, especially in the light of COVID. How have you decided when to start surgery or when you can do surgery in those patients? Does it truly need to be done that evening? Can it be done in a delayed fashion? How do you go about doing it?
So I think the most important thing to keep in mind, and several studies have shown this, the biggest significant risk that is modifiable is endophthalmitis. So in my mind, the most important thing is get the antibiotics in. Even if you can't make it to the OR, get some antibiotics in, and the patient has a fighting chance. But especially with COVID, that oftentimes makes it very difficult to get into the OR same day or even the next day. And I think in a lot of cases, even with IOFBs, a slight delay is okay and is acceptable. Of course, with that several years back, and granted, this paper looked at high velocity fragments from shrapnel. A delay in surgery in those cases did not affect the final outcome. But I do believe that even in your typical IOFB cases, if there is a slight delay, as long as you got the antibiotics in, you're okay. And then with retinal detachments, there's a lot of controversy here, but I think many studies, there was a large study from a meta-analysis looking, I think, between the years of 2006 and 2016, which showed that the timing of retinal detachment repair after trauma really didn't matter, and going to surgery earlier did not result in a better outcome in terms of anatomic success or in terms of final visual acuity.
Mm-hmm. Great. Yasha, what do you do for trauma cases in New York right now? Are you able to get into the OR rapidly? Is that something you're concerned about? Or do you just say, well, I'll book this in a day or so, I'll put the patient on systemic antibiotics and just watch them until you can get a OR time that's reasonable during the day, for example?
I think for ruptured globes, we take them right away to the OR. And I can't stress enough, I think Alex just nailed it with getting intravitreal antibiotics into the eye to prevent endophthalmitis, right? That's the number one priority. And the work that Alex was citing was I believe it was Marcus Collier's work from Operation Iraqi Freedom and Enduring Freedom, looking at the shrapnel injuries where patients actually had to come back to the United States to Walter Reed to get surgery. And I learned a lot from that because we do have a fair number of IOFBs. And sometimes I find that removal of the IOFB concurrent with the ruptured globe can actually cause more iatrogenic injury than doing it in a staged way. So oftentimes I'll like to just close the globe, get the antibiotics in the eye, and then wait a day or two once the globe is better formed in order to get the IOFB out. And that's typically done in conjunction. I have our anterior segment surgeons close the eye, and then the retina team goes in about a day or two later to get the IOFB out.
Let's switch gears and talk about macular holes, and particularly non-closing or recurrent macular holes. So Peter, your talk was on this topic. There's so many different techniques out there. What's your sort of go-to or preferred methodology to address non-closing of macular holes?
Yeah, I'm not sure if the team could do the video, but recurrent holes, large holes, more than 400 microns, myopic holes, chronic holes, these are all what I would consider complicated holes. For the ones that haven't been previously operated on, I prefer to use an ILM flap. The technique I use is that I make the flap temporally. That allows the flap to actually flap over the hole when you go to air. So it makes it very simple. You don't have to do anything except use physics. I don't like to shove the ILM flap into the hole. I think that impedes closure. I really just am trying to lay it over the top to give scaffolding for the retina to close. Now, of course, there are some recurrent cases where a good ILM peel was performed at the first surgery. And in those cases, I use what I call a pedunculated flap. So I make a flap also temporally, but make it larger than the distance between the hole and where the previous ILM had been peeled to. And so the flap is actually at the edge of that ILM peel. And then you actually have a very large flap that goes from temporally usually back over the hole. And in the last way, if you have really no way to do a flap, you could try a free flap. The problem is it's just really hard to get the free flap to stick over the hole. Again, I don't really like to shove it in. If I'm going to be shoving something into the hole, I'll do an autologous transplant, something Tamer Mahmood has been talking about quite a bit. Steve Charles also. Basically, you take a piece of the retina from somewhere else, you move it under PFO, you place it into the hole. You want to make sure that autologous transplant is larger than the hole, so kind of stick it under the edges of the hole. And the other thing I've been doing, I'm not a big fan of the autologous transplants, but another thing I've been doing in some of these recurrent holes is sometimes, there's just something holding up closure. And so I'll just take a 41 gauge cannula and inject some BSS like we would do in translocation or in subretinal surgery in the 4 quadrants around the macular hole to basically bleb up the hole and allow some of those attachments to be broken. And just by doing that, sometimes in these recurrent holes, you can get it to close. But these are tough cases for sure.
Yeah. Yasha, any experience with, these autologous flaps or amniotic membranes that you can talk about?
Yeah, so I thought that was just like an awesome overview of like what to do when there's ILM around the hole, when there's not ILM around the hole. I kind of love that pedunculated flap. I haven't heard that one where, I would think it'd be quite difficult just because the ICG and, tissue blue staining that far out in the periphery is hard. So if you're pulling over, an 8, disc diopter flap to get over the hole, I think that could be pretty challenging. I do the subretinal blebs to dissect the hole as sort of the go-to strategy, especially if they're not very myopic. But it's important to realize there's certain intrinsic limitations when they're severely myopic and there's myopic degeneration that would preclude appropriate dissection from the subretinal blebs.
Justice, how do you approach your thoughts around just ILM flaps? Is it for all macular hole cases, particular holes you do? Where do you incorporate this?
So actually, I take a little bit of a different view. I hardly use it at all. I'm still not convinced around the visual acuity outcome differences, between the eyes that, you're getting the anatomic closure and versus some of these holes where if you do the ILM peel and you get a flat open anatomic configuration where the hole's smaller, you get some level of visual acuity improvement. So generally speaking, I thought Peter outlined it very well. In most of these cases, if I'm doing the primary surgery, I often, we use intraoperative OCT to look at hole configuration, but I'm usually doing a very large ILM peel. And it's interesting, Peter was talking about the pedunculated approach. In most of the cases, if I've done the initial surgery, it would be so far out to try to bring that around. And Yasha highlighted how difficult it would be just to keep it intact. Then I think the next step is to go to either, I do like the concept around the submacular fluid and the 41 gauge cannula. Some of Tamer's data is really intriguing around the autologous transplants. It's hard to wrap your head around, but some of the OCT data where he has relamination of things like the ellipsoid zone and some really good visual acuity outcomes, I think it'll be very interesting as we understand that more and more. He's doing that in some primary cases, which is very intriguing also. So I don't do a huge amount of ILM flaps. I tend to use C3F8 a lot in those cases, and generally, I think that overall, especially the trauma ones, they're tough cases, generally.
Yeah, I've done the autologous now 3 times. Every time I've done it, I've learned something new. And I've also had more of my liver been destroyed that night because of the amount of effort those surgeries take. And honestly, each time they don't tell you little things about that surgery, which I think are so important. For example, the slight little piece of retina you leave should be the closest to the macula, and that should be the last piece you take off under PFO. And I think that they don't really talk about that a lot. In this last case, I actually realized that was actually the perfect place to put it. So that way you could immediately break that last bit of tissue and drag it under the PFO, which is arguably quite difficult. I had to go to bimanual a lot of times approaches when I had to do that too.
Yeah, I agree with you, Rishi. I think the biggest tip I would give the audience about autologous transplant is pray prior to the surgery. The other things are use endolaser to the donor site, not cautery. Number 2, I learned in one of my cases that I don't understand how it happened, but retina will float on the surface of PFO, and there's no way to get it to go down if you, for some reason, let go of it. So you really want a big PFO bubble, not a small one, and really be careful not to let go of it in any way. The other thing is really, you think, because we're so used to not doing bimanual these days in diabetic surgery, this is one situation where you don't want to use the light pipe. The light pipe is warm and the retina will stick to it. So don't use your light pipe as your second instrument when you're using autologous. But there's a steep learning curve. It's a tough case, but when it works amazing.
Yeah, it's interesting that along those lines of things to learn, and Tamer has talked about this, they used to primarily try to get it under the retinal edges and still in some cases, do that. Sometimes, and I think, Rishi, you alluded to this and Peter as well, the size of the graft is so critical to make sure that you don't undersize it, because then it's just not going to work. And they've shown that even putting it over, the top, where you have essentially the photoreceptors on top of the ILM at the edge of the hole, it baffles the mind a little bit how it ends up looking, how it does. But I also think keeping the PFO in immediately after surgery and coming back later is a critical step, rather than just going to oil as well.
Yeah. Lastly, I think we have a few minutes. We'll just talk about positioning, because I think there's been a lot of controversy about face down, no look up, no positioning at all. Like, what does the most recent data tell us? Alex or Justice, do you want to take this question?
Alex, you or me?
Why don't you go ahead first, Justice? I'll take it after you.
So this is obviously a very controversial area, and I think the data repeatedly shows that there's a large percentage of patients who don't need to position, or at least need minimal positioning. My challenge with it, and especially our smaller holes, there's been multiple studies that have shown overall good success rates, but generally there's a number of those studies that don't approach our 95 to 99% success rates with face down positioning. And so, I think that my challenge with it, I still do positioning. I know that in 80 to 85% is my estimation. I'm having people position who probably don't need to. I think that what we'd love to have is really, really strong biomarkers of those people who don't need to position that long. We've looked at it at the intraoperative OCT side, and one of the things that we found was that the tissue changes after you peel ILM are probably one of the most predictive factors in how fast a hole closes. And it makes sense that it may be a surrogate for tissue elasticity. Mm-hmm. And so, I think we're looking at that. Right now, the best thing we have is size. And there's obviously post-op one day OCT, which I think can be helpful as well. But I think when we get more data and a little bit more imaging information, we'll be able to customize this more and help from a quality of life standpoint, with our patients while maintaining our really excellent outcomes.
Alex?
So I I used to use post-op day 1 OCTs a lot, especially when I was fresh out of fellowship, because I remember actually I did the study with you, Justice, on post-op day 1 imaging, and really you cannot get a good view of the macular hole if the patient is phakic. The OCT image does not allow you to get a reliable view time after time. Sometimes you get lucky, but in pseudophakic patients, a lot of times you do get a good sense of whether the hole is closed or not on post-op day 1. And I used to do that, but then more and more, especially not at Cole. You know, at Cole it's very convenient. We do a lot of these cases where they're combo cases. We have the cataract surgeon to the cataract surgery, and then we come in and close the hole. But sometimes, for example, at Metro, I've moved away from the combo cases, and now I don't do as much post-op day 1 imaging, and I just don't see that there's usually no harm in just asking the patient to position, and like Justice said, the outcomes are great. Well over 90% primary closure. So why not just ask them to position and just don't even think about it?
Well, thank you both all for this panel, and thank you for all watching on today's program. And for the last winner of the raffle, I'm not even sure what they're getting. Oh, Yeti microphone. I'm sorry. They're getting a Yeti microphone. Actually, it's the winner is Hong Yui Hui, and she's actually our newest Retina fellow at Coli. That was not intentional, I promise you. That was truly random. But Hong Hui, you're going to get a Yeti microphone in the mail, or maybe we'll just save it for you and get it when you come here. But regardless, you're going to get it. And so thank you all for watching this program. I first and foremost want to thank our co-directors of the program, Peter Kaiser, Sunil Srivastava. Thank you for all our wonderful participants. This program wouldn't be as good without your talks today, so thank you all. We reached a record number of people through this webinar series. I've been impressed with how many times we've been successful at doing this virtually and getting even a larger audience than sometimes we do in person. So it's really great to see all of your interest in the program. And thank you both Jar and Alana for your coordination of these activities. This program would not run as seamlessly without you guys behind the scenes. And for those who want to obtain CME credit, there's a link that you're going to have to follow either by the platform or through your email to fill out the post test, and then you'll get your CME credit for today's program. So thank you, and see you next year.